Okay, so hello everybody. My name is Adriano Massuda. I'm a professor at Fundação Getúlio Vargas. I'm studying health system and management, and I'm very happy to join this event that started this morning discussing the pandemic. The COVID pandemic is not only a virus problem, but is a issue of how we could organize our health systems. And today we're gonna doing the continuity of the event. This event organized by the Institute of Advanced Studies of USP, with in cooperation with the Dave Rockefeller Center for the Harvard University for Latin American Studies at Harvard University. So I'm very happy to join the this event, and we're gonna discuss now the long-term impact of the pandemic with three very special guests. Professor Noreen Goldman. She is a professor of demography at the Princeton University. Professor Aloysio Segurado. He is a professor of infectious disease, a full professor at the University of São Paulo. And Cássio Maldonado Turra. He is professor of demography at the Federal University of Minas Gerais. So we're gonna have 20 minutes of presentation for each one of our special guests. And then we're gonna have 1 hour for discussion. So I think to start, I would like to invite Professor Noreen Goldman to open our work for today. Thank you, Noreen, for your participation.
Okay, thank you. Thank you for inviting me. And let me share my screen. Okay, can everyone see that okay? I'll take that as a yes. So what I'm going to present today is the impact of COVID on life expectancy in the US and by race and ethnicity. And this is work that is largely joint with Teresa Andresfay from the University of Southern California. Okay. So to give it a little background, we started this relatively early in the pandemic when there were many news reports talking about the unequal burden of COVID infection and mortality borne by minority groups, particularly the Black and Latino populations in the US. The data were basically counts of deaths and counts relative to these groups' proportion in the population. And much of the very early news reports centered about New York City, which was the epicenter, as many of you probably read about during the very early stages of the pandemic in the United States. Okay, and many of us are demographers, we know that counts of deaths or counts relative to population is not a great way of measuring mortality impact, largely because these populations have very different age distributions, Latinos and Blacks on average being younger than the white population. So we made a set of estimates. We made the first set, as I've noted in the slide, that in October 2020, the first set revisited a few times, and it was published in the Proceedings of the National Academy of Sciences in February 2021. Those early estimates used partially projected numbers of COVID deaths since 2020 was not yet a completed year. Okay, we then updated those estimates in April 2021, and that appeared last month in JAMA Network Open. So I'll summarize mostly the updates. And then I'd like to go on and say something about how these estimates compare to those released just several days ago by the US Vital Statistics Office, what I'll call the Centers for Disease Control, the division that released this. And I'll focus, I should say, on life expectancy at birth, although we also looked, for example, at life expectancy at age 65. I won't mention that right here. Okay, so here are just the two papers easily available that I'll summarize in the beginning of this talk. And I'll try to pause every now and then because I know I speak very rapidly and I don't envy anybody trying to do simultaneous translation. Okay, so some of us are very familiar with the concept of getting life expectancy for a year. What it really is, it's a very hypothetical notion. It's how many years people could expect to live if they experience the mortality conditions, that is, the death rates of a given year throughout their lifetime. Another way of saying that is, with the example of 2020, if those rates stayed the same for the foreseeable future, right? And nobody is subject throughout their life to the death rates of a given year. So no cohort will experience the kinds of numbers we'll be talking about, but it's a very good summary measure of what mortality impact there was in a given period. It's independent of the age distribution, and it allows us to make historical and international comparisons. Okay, so this slide shows the data that we use to make estimates of life expectancy in 2020. I'll focus here on the right column, the updated estimates, which didn't use any projections, used the actual deaths reported, although they are provisional because not enough time has elapsed for the Center for Disease Control to check all the deaths. They get reported at different times, to different levels of accuracy by the different states. In total, our estimates are based on 381,000 deaths that occurred during the year 2020. Okay, again, they're called provisional. We compared that with what mortality was in 2018 because that was the most recent year that was available at the time that we made these estimates. 2019 were not yet available, but we now have enough information to know the estimates would be almost the same. So by comparing 2018 to 2020, we're basically saying what is the impact of the pandemic compared to just before the pandemic. Okay, so I won't bore you with details of how we did the calculation, but let me just make a couple of rather critical points. Okay, so basically what we did is we took that 2018 life table and assumed that's what people would have been exposed to had we not had COVID-19 come into our lives. Okay, then we assumed that people who did not die of these other causes were also subject to COVID-19. So we essentially added COVID-19 mortality to what the life table told us before the pandemic, okay? So it makes a rather strong assumption that is that were there no COVID deaths in 2020, life would have gone on in the same way from all these other causes as it had done prior to the pandemic. We kind of call that an assumption of independence of causes, COVID versus the rest of the causes from which people die. Okay, so here are the results. Okay, the red is what the life table told us prior to the pandemic. It's labeled absent COVID-19. The blue tells us our estimates for 2020, adding COVID deaths to that pre-pandemic experience. The length of the bar tells you how much life expectancy at birth declined. You can see the estimates for the overall US population, Latinos, whites, and Blacks. Okay, and what should be immediately obvious just by looking at the lines is the longest line is for Latinos, a decline of just over 3 years in life expectancy based on our estimates. For the Black population, a decline of about 2 years and a little under 1 year for the white population. And I'll update these estimates a little bit later from the CDC. If we put these on graphs, which actually go back to about 40 years, it can show you that the single year decline shown in the dotted lines for each of these ethnic and racial groups is mammoth. I mean, it's a huge decline to be experiencing in 1 year, and no single year during this period has had such a decline. In fact, we either have to go back to World War II. There's some disputed numbers about deaths in 1942 in the US, or we have to go back to the 1918 flu pandemic to get a decline in 1 year as large as what we estimate for the year 2020. And let me make one more point on this graph, which is if you look at life expectancy at birth, it's probably going to jump out at you that the highest numbers are for Latinos. The lowest numbers are for the Black population. So that is to say, prior to the pandemic, Latinos had higher life expectancy than whites and much higher than Blacks. Something many of you are probably familiar with, something called the Latino paradox, a paradox in the sense that social and economic characteristics of the Latino population are far worse than the white population. Yet prior to the pandemic, they lived about 3 years longer on average than whites. Okay, so why these huge disparities? This is what has made the press for many months in the US. Okay, the persistent social inequalities, structural racism, these are the kinds of headlines that have appeared in the US to point to the much higher mortality burden among both the Black and the Latino population in the US. Okay, so there's higher exposure to COVID-19, there's higher mortality for those infected. Some of this breakdown into these two types of risk factors is a little bit arbitrary. But by and large, both Black and Latino Americans were more likely to be employed in what we call frontline occupations, jobs that could not be done at home, jobs that were often in informal work, jobs of relatively low socioeconomic standing in which workers were pretty unlikely to be able to protect themselves, and employers also were less likely to protect their workers. These are groups that were more reliant on public transport, that lived in crowded, multi-generational households. And there's an asterisk on some of these because these factors were especially true for Latinos, in addition to also being true for the Black population. And for Latinos especially, there were language barriers in terms of information about how the virus spread and how to protect themselves from that spread. And then both groups, but particularly the Black population, had higher rates of chronic diseases that might have made them more likely to get COVID, but was especially more likely to lead to severe disease, hospitalization, and potentially death. Things like hypertension, heart disease, cancer. For the Latino population, it was particularly diabetes and obesity. Okay, lower access to healthcare for both groups, and especially for undocumented immigrants, no eligibility for health insurance, but also for benefits during the pandemic, like unemployment, stimulus checks, and lower quality of healthcare for both groups. Okay, so what are the takeaways? The takeaways are clearly there was a huge impact on mortality decline for 2020, especially for Black and Latinos, but there will be an impact in 2021 in the US as well. So we made an estimate of what the impact was just through early April of 2021, and that implied a 0.6-year reduction in 2021 life expectancy compared to prior to the pandemic. So the decline will probably be less than we estimated for 2020. We estimated 1.3 years, but as many of you know, deaths are continuing to occur at lower levels because of vaccination, but yet very uneven vaccination uptake in the US. Okay. Through early April, there were 159,000 deaths that led to that projection of 0.6 year. As of today, it's about 225,000 in 2021. So these disparities will persist. These data indicate Blacks and Latinos continue to die at higher rates. And these are also the groups who are less likely to be vaccinated. So those differentials will persist and potentially increase. So I ask now about the accuracy of our estimates, okay? The death information is provisional. It continues to be provisional. It takes the CDC a long time to get all the data in and do their final checks. But the issue that concerns me, that concerned Teresa and myself as we were doing this, was that assumption about independence of causes of death, right? If there had not been COVID, death rates would have looked just like they did prior to the pandemic. And the only thing that changed in our assumption was that COVID deaths got added. There was no allowance for other causes of death to potentially have increased or decreased because of the pandemic. Why do we make that assumption? Because we only had mortality data for COVID deaths. We didn't have all deaths in 2020 at the time. In fact, they've just come out in the last few weeks. But there's reason to think, that other death rates may have increased in 2020, not just COVID. Other causes may have led to higher rates because care was delayed. People just didn't get treated because of fear of contracting COVID, of going into healthcare settings. The quality of care in many places was lower. Hospitals were overburdened, ICUs were overburdened, equipment was lacking. People had symptoms of COVID for many, many months, some still do, which may have increased risks of dying from other causes. There may have been, and there was, higher crime, higher external deaths, causes of death from external causes like drug use and alcohol use, brought in part, although not entirely, from the social and economic consequences of the pandemic. At the same time, death rates from other causes may have gone down. There is a phenomenon with a very unfortunate word called harvesting. That is, people who are already very sick in 2020, late stage cancer, severe heart disease, now exposed to COVID, may have died, I say first, from COVID, in the sense that if COVID had not come around, they may have died soon after from cancer and heart disease. And so we're not seeing deaths from cancer or heart disease at the rates we might have otherwise. And there's miscoding of cause of death, which could have led to under or over reporting of COVID deaths, especially in the absence of tests for infection. Okay, so in the past week, the National Center for Health Statistics, the CDC, which is part of that, provided their estimates. Their estimates are now based on all deaths in 2020, not just COVID deaths. So they no longer have to make this assumption of independence of causes as we had. And the question is, are their estimates consistent with what we got? And as you can see from the slide, there was a lot of press in the last few days. Even though much of this information had already been released from work that Teresa and I had done, from some papers others had done, this was the official US take on what the impact was in all of 2020 compared to what happened in their case from 2019. How much did mortality decline? How much did mortality go up? How much did life expectancy decline? Okay, so what did they estimate? Okay, first they estimated an overall decline of 1.5 years in life expectancy in 2020, which is slightly higher than our estimate of 1.3 years. Not surprising, since, as I said, we expected other causes to have increased, not just COVID. Okay. Their estimate for Latinos is a 3-year decline in life expectancy, the same as our estimate. Their estimate for Blacks is larger than our estimate. We estimated around 2-year decline. They estimated just below 3. What this means is the Black-white disparity, which had been about 4 years, Blacks lived about 4 years less than whites prior to the pandemic, increased to almost 6 years in 1 year. It had been 7 years in the early 1990s. That was a disparity that was gradually getting smaller, not small enough, but it was on a steady decline, and it now increased enormously in 1 year. The setback for life expectancy in the Black population was about 20 years, just based on 2020 deaths. Latinos experienced the largest decline of the groups they looked at. It was 3.7 years for men, a little over 3 years, men and women combined. 90% of that decline in Latinos was just due to COVID, more than for other groups. Other groups had excess mortality from other causes. For Latinos, it was primarily COVID. Male was higher than female mortality from COVID. The male-female gap increased, as has occurred in all countries for which we have reasonable data. Some causes did go up for 2019 to 2020. accidents, injuries, particularly drug use, homicides, diabetes, liver, while other causes of death decreased over this year, particularly cancer. And that may reflect this issue of harvesting that I mentioned, that people who had been in very late stages of cancer, also other severe lower respiratory diseases and heart disease, may have succumbed first to COVID. And interestingly, suicide went down, contrary to maybe many people's expectations of what would happen in 2020. They did not produce estimates for other racial and ethnic groups because of high rates of racial misclassification. But I'm going to give you a 1-minute look at what happened to Native Americans, a group that got tremendous attention early on in the pandemic in the US, because they also, as with the Black and Latino populations, appeared to have very high rates. And I don't have life expectancy measures for them. So these are done on something that did standardize for age, indirect standardization. And this just shows you a little bit of the media attention that the Native American population received. So here is the graph. It shows you, if you simply looked at crude death rates, deaths per people, relative to whites, this is all relative to whites. These groups would not look so high. Latinos would not look high at all. If you standardize for age and county, you can see Blacks and Latinos have much higher rates than whites, but it's the Native American population that has by far the highest COVID death rate in 2020, almost 3 times that of whites. And my final slide, this is based on a paper that's in the medical archive site under review now, that says the rate in the Native American population is highly correlated with the proportion of Native Americans who live on reservations. These are largely American Indian reservations. And it points to the fact that these reservations, this is aggregate data. We don't have individual data that would link COVID mortality to these characteristics, but people living on reservations have higher exposure to many of the risk factors that we assume are important in COVID: crowding, multi-generational households, poverty, high rates of chronic diseases that make them susceptible to COVID, like diabetes and obesity, high rates of smoking, high rates of being frontline workers, and low quality of healthcare. And I thank you. And I thank you again for inviting me to this conference.
Thank you, Professor Noreen. Very interesting presentation showing the impact of the COVID pandemic, but how the impact of the whole disease in the American population and how unequal it was in different groups of population. Let's go to discuss the consequences of COVID pandemic in life expectancy in Brazil. And I'd like to invite Professor Cássio Turra. As I said, he is professor at the Federal University of Minas Gerais. Cássio.
Thank you so much, Adriano. Thank you, Marcia, for the invitation. Thank you, the University of São Paulo as well. Let me share my screen. So as Adriano mentioned, I'm going to talk about a recent paper led by Marcia Castro, a paper that I had the privilege to co-author on the life expectancy reduction in Brazil after COVID-19. So most of my presentation will be based on this paper, but I will try first to give some context in terms of mortality trends in the world and in Brazil and Latin America. And also at the end, I will give more food for us to think in terms of long-term consequences for life expectancy in Brazil. So I would like to start by sharing one tweet I wrote on early March this year when death toll in Brazil was increasing very fast. I guess I was really frustrated at that point. So my sentence here, these 2 sentences, they reflect my frustrations. with the fact that we were, there have been at least 300 years, 250 years since the mortality transition started in the world. And at that point in March, we were kind of living at the mercy of the virus in Brazil with this increasing death toll. So I said the demographic transition represented the victory of order in a world marked by frequent mortality crisis. Had we not drastically increased control over death, nothing that we know today, economic, social, and political systems would exist. So these transformations in the last 300 years were really important. And we are facing this mortality crisis in a completely different scenario that mortality crisis used to happen in the past. So at least since the late 18th century or the 19th century, the world has witnessed increases in sustained fall in mortality, especially starting in Europe, Japan, and the US, and then later on in Latin America, Asia, and now in Africa. Increases in best practice life expectancy, so the countries with the highest life expectancy in each year, as we can see in the graph on the left, have been almost linearly since the late 19th century. The stories are a bit more complex or complicated when we look at individual countries, of course, as we can see on the right side. Some countries have witnessed faster improvements in mortality. Others have shown some reductions. But when we look at the best practice life expectancy, what we see is this linear pattern over the years. On the right side, we can see, for example, that we can see mortality crisis happen during this time. For example, in the case of the US, we can see the Spanish flu in the 1918, the Second World War here for Japan, but they were then recovering and catching up. So there's a lot of discussion about what's going to happen in the future. Of course, we're going to stay on this line. Countries that are going to converge, diverge over time, but questions about the limits of human life. But this is important to have in mind in terms of secular trends for our discussions for Brazil and for the current scenario. In the case of Latin America, the mortality transition in Brazil started around 80 years ago. It started in São Paulo, Rio, in the south of Brazil, and then it reached other regions of the country. It was in the 1940s that life expectancy exceeded 40 years at birth, initiating what we call a sustained fall. But we were behind at least 4 or 5 countries: Costa Rica, Cuba, Chile, Uruguay, Argentina. All these countries started the mortality transition before Brazil. So Brazil started late, and as we can see here from 1970, that we were lagging behind these countries, but we have been catching up these pioneer countries over time. Although there is still room for improvements, mortality improvements in Brazil, if we take the Latin American levels as our best practice for the next years. So it was in this context of survival gains over decades that the COVID-19 hit Brazil and hit the world. There have been many calculations of the excess on mortality during 2020 and 2021. As we can see here from the Financial Times, these calculations that show the excess of mortality, measuring both the direct and the indirect effects of COVID-19, taking as a reference the trend, the historical trends. Right? But in case of Brazil, as we can see, and there are many reasons for that, the excess of mortality was somewhat high in 2020, about 22% of the expected deaths. And in 2021, it was really hard. At this point here, there was 67% excess mortality. And now I was just checking today, 65 now with the recent decline. But it's a very large increase in the number of deaths compared to previous years. Right. Some demographers, in the first months of the pandemic, some demographers had written that age structure would explain all this difference across the world, but as we can see, this age structure is not the only explanation for the difference, for this large variation. Inequality is important. The supply of healthcare, of hospitals, the types of policy that governments put in place, labor market and types of residence, demographic concentration, and so on. So there are a lot of things that we need to take into account to explain this difference. In Brazil, the story has been really hard. So one very strong, powerful way of showing the excess of mortality in Brazil was by calculating the reduction in life expectancy. And that's what's the main motivation of this paper, as I said, led by Marcia Castro and co-authored by Suzy Guzenda, myself, Sun King, Teresa Andresfe, and Noreen Goldman, who's in this section together, in this table together with us. So our main question was how strong was the effect of the excess of mortality of the COVID-19 pandemic on the 2020 life expectancy in Brazil at birth, at age 65, by sex, by state, and also in 2021, given that, as I showed, the excess of mortality was, the death toll was really much harder than in 2020. So for that, we calculate three different measures. The first one was the difference in life expectancy in 2020 and 2019. So we calculate life tables for both years and simply measure the difference in the life expectancy. The second one was what we call the cause-deleted life table for 2020. So we took the 2020 life table and we deleted the COVID-19 cause of death. Noreen already mentioned a lot about this, so I don't think I have to talk a lot about these methods, but they are different. One thing, the first method measures all the direct and indirect effects of COVID. We're getting everything, not only the direct effect of COVID on mortality, but also increases and declines in mortality of other causes. The second one, we are deleting only COVID-19 cause of death from the 2020 life table. And the third one, we added COVID-19 deaths to 2019 life table. We also measured the 2021, as I said, impact, and for that was a little bit more complicated because we didn't have data source data at that point. So what we did was to estimate what would be the expected number of deaths in 2020 if the life table for 2019 was working in 2021. So we estimate the number of deaths based on that. And then we added the COVID-19 deaths using alternative data source. And then we assumed that, we did this for the first 4 months of the year, and then we assumed that after that, Brazilians would experience mortality based on the 2019 life table in 2021. We also estimate the percentage loss in life expectancy in 2020 relative to the gains that occurred 20 years before, and the setbacks in life expectancy for both 2020 and 2021. Looking at how many years we went back in terms of life expectancy with this effect of COVID-19. So as I said, we used the seen data 2019 and 2020 same data. 2020 is provisional, right? We didn't correct for underreporting of deaths, maybe some underreporting of deaths for 2020, maybe larger than in the other years. But since we are measuring differences, counterfactual measures and difference between years, the effects of underreporting of deaths should be minor, unless there's some special underreporting levels in 2020. But we don't think this is going to be that different from the other years. So we use IBGE population life table projections, and as I said, for 2021, we had to use alternative data sources to estimate the number of deaths from COVID-19. So these are a summary of some of the results. As we can see, the effects are larger for men than women. As we know, there's been a lot of news about this, but it's larger for men than women, regardless of the method that you use for both years, 2020, 2021. Another thing is that the effect for older age has been relatively larger in 2020 than 2021, which is probably caused by the fact that the disease or the mortality pattern of the disease has been rejuvenating since 2020 to 2021. And also you can see there are differences between the methods. So when we calculate the effect based on the difference between the 2 years using the whole all cause of death, we estimate the effect of 1.31 years in life expectancy at birth. It increased 1.92 if we use the cause-deleted method for 2020. And the reason Aurin already mentioned the fact that for these two methods, we have to assume that COVID-19 is an independent cause of death. And that's probably the reason why we are getting higher impacts with these two methods. In the case of the difference, we are getting effects in both directions. So the increasing mortality due to the COVID, but also declines in other causes of death. For example, because of competing risks, since people who are more fragile may be dying from COVID instead of dying from these other causes. But in 2021, the impact is larger, but again, it's a different method, so we cannot compare directly with the other three, but we know from the excess of mortality that the impact has been really large. And also, I must remember everybody that this captures only the 4 initial months of the year. And we assume that for the other 18 months, Brazilians would experience the 2019 levels of mortality. So probably this may get worse once we have the data for the whole year, unfortunately. The impact has not been uniform across the Brazilian territory. We have been following also the news about that. So when you look at 2020 only on the left side here in the map, these colors represent the impact at birth and age 65. Of course, they are correlated, especially in 2020. So the largest impact has been in the north region, Amazonas, Pará, and Amapá. In the south of Brazil, the center south of Brazil, which was the region that was the last one to be hit by the virus, has experienced the lowest decline in life expectancy, the smallest decline in life expectancy. In Northeast and Rio and Espírito Santo, they experienced like an intermediate scenario. This was 2020. In 2021, when we compare the decline at birth for both 2021 and 2020, we can see that Amazonas, Roraima, and Rondônia, Mato Grosso, these states were the ones that were most hit both in 2020 and 2021. So they have been suffering from the death toll in both years. And then we can see a change in the patterns as the disease hits the southern and central states. There have been like a larger impact in 2021 in this region compared to what had been in 2020. And while in the Northeast, at least in these three states, Bahia, Piauí, Maranhão, the effects were harder in 2020 than in 2021. So this regional parts are really interesting to examine in more detail, and they show how the disease is spread through the territory over the 2 years. This huge impact represented important setbacks in the 2020 life expectancy in Brazil. In this table, I will not go into the details, but these tables show the states, the life expectancy at birth, life expectancy at 65 in 2020, and what the life expectancy in 2020 represented in terms of the mortality levels in 2020 represented in terms of life expectancy back 10 years ago. So we calculated what would be the level of life expectancy in 2020 that corresponds to the life expectancy levels in the past. And dark red shows where the setbacks were harder. So of course, this includes males, the North region, Northeast as well, and showing that in 2020, this reduction in 2020 corresponds to returning to early 2000 mortality levels for those regions. It's really important fact. So what can we expect for the future? In this paper, we concluded that life expectancy will not rebound in 2021. So this is something really particular in the case of Brazil, is the fact that we're going to have 2 years, consecutive years of mortality decline, of life expectancy decline. Life expectancy decline in 2020, and it will be at least stay the same, we stay reduced in 2021. Probably will decline even more in 2021, as we showed. We also conclude that the pre-pandemic trajectory of annual gains in life expectancy, the ones that I showed in those first graphs, will likely slow down in the future. And we presented a few reasons for that. The first one is the transmission and the death toll in 2021 that remains high. So I already talked about this. The second reason is the disrupted primary care services in Brazil because of the pandemic. So screening for cancer, the reduction in new diagnoses, the reduction in child immunization, the postponement of medical treatments, the worst health conditions in the population, all these things together can impact life expectancy in Brazil, at least in the medium term. That's what we argued in the paper. There are also the long-term consequences of COVID among the survivors. I talked that I guess we're gonna hear more about it in a second. But here we're talking in terms of the neurological, the cardiovascular, the pulmonary complications of COVID that may increase the risk of death of those who are now considered recovered from the disease. And this may happen in the next years as well, so affecting life expectancy in the next years. Economic crisis, considering that it may have worsening unemployment rates in Brazil, increasing and reducing family income, it may have an impact as well, even if indirectly, on life expectancy in the next years. It will depend a lot on our social safety net or income programs that we can offer to those that are poor next year and in the next months. And related to that, the reductions in public health budget. We don't know how this will If the economic crisis stays longer, of course, this is going to affect our ability to fund public health in Brazil. And this may have also consequence for medium-term long consequence, not just the short-term consequence that we are talking here in terms of the life expectancy impact. Well, this is my own view. So this is what we discussed in the paper. So I would like to end with giving more factors for us, more points for us to discuss and think in terms of the medium long term. So I've added here a few reasons for seeing the glass as a half full. More cash, maybe more optimistic, but cautiously optimistic. I'm sure that maybe this is not the view from Marcia, Noreen, and other co-authors, I don't know. But I wanted to add these other points so we, in a way that we can have more discussion at the end of the table. So in terms of short term, I guess maybe we can get more optimistic if we think in terms of the high vaccination coverage that we can get by the end of 2021. If this is the case, and if mortality keeps declining, the number of deaths keeps declining, like in the US, Israel, I guess we can get in 2022 a rebound in life expectancy and maybe coming back to 2019 levels. I think it's possible if we accelerate the vaccination coverage in the next months of the second semester of 2021. In terms of medium term, we have to think that some other factors. One is mortality selectivity. So as we've seen, there has been like a really huge death toll from COVID. And it may, one of the consequences of this excess of mortality was taking lives of people who are more frail, more fragile, that would have died in the next years from other causes, but unfortunately, very sadly, had to die or died in 2020, in 2021 because of the COVID-19. So this may have a positive effect in terms of life expectancy in the next years. Again, this adds to the discussion of the long-term consequences of COVID-19. I think these things go in different directions. That's why I'm adding these things here for us to discuss. The SUS, the public health system in Brazil, and I guess it gained support from the public opinion in Brazil. This is one thing that I was in a seminar the other day with a colleague from the UFMG, and we were discussing from the medical school, and we were discussing about that, how the university, public health, gained support from the public opinion. People understood the importance of SUS, the importance of university, the importance. Of course, there are people that are denying science and so on, but a lot of people start to be aware about the importance of the university and the science and the scientific work and the public health. So I think this may help SUS to get funding for the next years, political support to improve funding. Economic recovery is a possibility. We don't know, economists don't know how much we're going to get in the next 2 or 3 years. The potential economic growth in Brazil is low now. We need to have productivity gains. So it's difficult to have like a huge increase, it seems, in the next years, but it can be, we can do better depending on how governments deals with the economy. In terms of long term, as I show in the first slides, there have been secular trends in survival. So we need to keep looking at the pioneers of this process because we are laggards. Brazil is lagging behind. So if other countries can reach higher levels of life expectancy over the years, it means that we can at least follow their trajectories, even if with some delay. So one thing that we have to look at is for the aging-related disease. So how Japan, other Asian countries, South Korea, France, Italy are going to deal with this aging-related disease. and how innovation, medical technology will help to reduce deaths from this disease and keep life expectancy increasing for these countries. In Brazil, as we saw, we are lagging behind. So I guess the expansion of education. We are education is really important for mortality levels. There are huge inequality in terms of the distribution of schooling years in the Brazilian population. So if the education expands faster and we provide timely and effective healthcare in the next years, so that we can fight better disease, man-made disease that still kill Brazilians, that could be avoided, including infectious disease, cardiovascular disease, and external cause. I guess we could expect mortality gains, survival gains in the next years, regardless of what we had experienced in the last 2 years because of the pandemic. So it's really important that we keep changing our structures in terms of inequality, in terms of healthcare access, in terms of education, in terms of public health messages and policies, so that we can keep following this secular trends and keep on track for better and longer lives for our population. So that's my last slide. That was the second part of my tweet. And I said exactly that COVID-19 virus hit Brazil like several other countries. However, so I was really frustrated to be at the mercy of the virus in 21st century, after science, and at that point, vaccination was already a reality. After science has already given many answers, is unacceptable. It's going back centuries. It's jeopardizing our future. That was my feeling. Unfortunately, we haven't changed much since then, but I hope that we can manage this situation by the end of the year and revert this terrible impact that we experienced these 2 years. Thank you so much.
Thanks a lot, Cássio. Great presentation of the huge impact of the pandemic in Brazil and also the consequences for our future. So I would like to invite Professor Aloysio to let us know more about what we can expect in terms of the long-term COVID in Brazil. So Professor Aloysio.
Okay, so thank you. Good afternoon. Thank you very much, Adriano, for moderating this session. I'd like to greet my fellow speakers and also thank the organizers and in particularly my good friends, Marcia Castro, Vera Paiva, and Lorena Barberia for the opportunity. Let me share the screen. I'll change gears a little bit from what has been discussed by the previous speakers in order to bring the perspective of where I come from as a healthcare worker. So as I was introduced as a professor of infectious diseases, it is important to point out that currently, apart from my clinical job, I'm also managing the Central Institute of Hospital das Clínicas, which is the largest academic health center in Latin America. And we have been really involved and actively involved in coping with the COVID-19 pandemic in Sao Paulo. So that's my point of view, and I'll try to share with you my expectations and concerns about the long-term impact of this pandemic in the healthcare perspective. So let's start by saying that from a healthcare perspective, we should think about healthcare provision as a clock mechanism in which different components are interrelated. So we cannot think about the impact of COVID alone in providing acute COVID care for severely ill patients who need hospitalization. but we also have to think of COVID-19 survivors who persist having clinical conditions that require sustainable healthcare, and the impact of our attention being drawn to COVID care, both to acute and long COVID care, in terms of the impact this may have in other healthcare demands we continue to have. And in particular, in our setting, which is an academic health center, this has to do with high complexity healthcare. So let's start by understanding what acute COVID-19 brought to us. As you all know, COVID-19 is an acute viral disease that can have a variety of manifestations in its clinical spectrum, ranging from asymptomatic infection to very severe disease. And for those on the top of the iceberg who really develop severe COVID, the disease progresses in 3 different stages. The first stage of early infection with let's say, non-specific signs and symptoms that are shared with other viral diseases. A second stage when the pulmonary involvement reaches its peak and patients who progress through this phase need to be hospitalized, and a third stage to which only few patients progress, but which demands intensive care because it leads to a hyper-inflammatory milieu that leads to severe pulmonary damage and respiratory failure that requires mechanical ventilation in intensive care. What happens if patients what happens to these guys that develop the 3 stages of disease? They usually recover or die in a time frame of 28 days. This is what happens to most of them. But apart from that, apart from those who recover or die, a significant number of patients overcome this critical phase but continue evolving with persistent symptoms, which is called long COVID. Let's think a little bit more in detail what this really means. So first of all, it's very important to have a clear notion that so far we don't have an internationally defined case definition for this clinical condition, long COVID. We have a list of signs and symptoms which are usually associated with this condition, but we don't have pathological correlates to most of those signs and symptoms. The long-term clinical consequences of COVID are described as comprising a wide range of persistent symptoms that may lead to substantial disability and impaired quality of life. According to British estimates, about 1/5 of patients persist with symptoms 5 weeks after disease onset, and 10% may still have those symptoms for more than 4 months. Reports have also tried to point out that persistence of symptoms in a long COVID syndrome more often occur in patients with the history of severe COVID-19. But it's important to highlight that this is not always the case. So we have clearly seen patients who have not been so severely ill at the acute phase, who may still persist with symptoms for a long time. And what has been already become a consensus is that this is an urgent public health priority. We should really take our time to investigate this in more depth. And for that, we need a multidisciplinary research effort to try to come up with a consensual clinical definition, to try to understand the pathogenetic mechanisms that may explain those persistent symptoms, to try to disclose predictors of development of this chronic condition. And finally, after we do that, to test effective prevention and management interventions that may lead to a lower proportion of patients with long-term disease. There is also the need to invest in epidemiological studies to try to understand the scope of this chronic clinical condition, its magnitude in terms of attributable risk, and the impact this may have in health systems. A number of signs and symptoms have already been associated with the so-called long COVID condition, but these are related to different organs in the body, clearly showing that this is a result of a multiple system involvement. There are general health and systemic symptoms such as fatigue, which are among the most common complaints of these patients. There are pulmonary symptoms such as cough, breathlessness, chest pain, and in some cases, impaired respiratory function. There are complications in the circulatory system that have to do with arrhythmia, myocarditis, the development of a hypercoagulation state, and in some cases, severe cardiac impairment. Many neurological symptoms that cover a wide range of different syndromes, the most common of them being the reports of prolonged headache, the loss of smell and of taste, peripheral neuropathic syndromes, encephalopathic syndromes, the so-called brain fog, a difficulty in keeping concentrated, and particularly an impaired visual selective attention, which may impair performance at school or in work. The muscular system is commonly involved with generalized muscle pain. Kidneys can have their function impaired. There are gastrointestinal symptoms such as diarrhea, nausea, and vomiting, and in some cases, impaired liver function, metabolic consequences such as hyperglycemia. And I would like to highlight the psychiatric symptoms that have to do most commonly with anxiety, depression, or even mood swings. How do we clear up the situation? How can we disentangle this large number of symptoms to have a clearer picture of what is going on and what we should expect? I would say we first have to have a critical eye on those cohort studies in terms of their methodological discrepancies. Many of the studies that have been published in the last 1.5 years have had different approaches. In terms of the study participants, some studies were restricted to laboratory confirmed COVID cases, while others included lab confirmed cases and suspected cases as well. The choice of outcomes has varied considerably in this diversity of signs and symptoms that were looked after. The assessment of outcomes has been different in many studies. Most of the studies have been telephone surveys with patients at home. In other studies, these have been developed in face-to-face interviews and clinical assessments, which are more objective in a way. The existence of controls is not always there. So we have cohorts that only include COVID-19 patients. So it's hard to distinguish whether these symptoms are really related to the COVID-19 acute phase or whether they might be due to other conditions. and duration of follow-up in those cohorts have varied also a lot. There is a basic question underneath, and that is if long COVID is indeed a novel distinct syndrome, because it could also have, in fact, it does have a lot of overlap with other previously described syndromes. And I would like to mention here the post-intensive care syndrome, which is a condition that affects patients who have been in prolonged intensive care and most often under mechanical ventilation for a long period of time using strong painkillers and muscle relaxants. Another syndrome, which is known as post-viral fatigue syndrome, which has been described as associated with a large number of acute viral infections that is mainly characterized by a chronic fatigue and an impaired performance when trying to return to routine activities after acute disease. And there is a lot of overlap as well in terms of psychiatric complaints with the so-called post-traumatic stress disorder. So what I really mean here is that we still don't have a clear understanding whether we are talking of a specific clinical syndrome or if we are talking of a combination of effects that overlap among each other and that have still to be disentangled from one another if we want to have a clear view of what to expect for the near future. What about the impact of COVID-19 in other healthcare demands? We have heard from Professor Goldman and Professor Turra that excess death studies have clearly shown, and these are data I collected from the CDC website, that show that if we collect data concerning mortality associated with respiratory diseases, circulatory diseases, malignancies, dementia, and some other causes, as mentioned here, we clearly see excess mortality in the second half of 2020 and along throughout the year of 2021 in the United States. This can be due to two different aspects. These could be misclassified deaths where their COVID-19 association was missed at a point because of the lack of appropriate diagnosis and testing, or this could be a consequence of people dying of other causes because of the reasons that have already been pointed out, for the lack of healthcare and more difficult access to routine emergency and routine care. In fact, there has been a number of publications so far that clearly point out for an impact of COVID-19 on both prevention and care of chronic conditions. There has been a reduced adherence to healthy lifestyles for many reasons that were explored in the panel this morning and also in this current panel regarding undernutrition or poor quality of food during the peak of the pandemic, the inability to perform physical activity, different patterns of smoking and alcohol use under the pandemic conditions, barriers to healthcare utilization, which have led to both reduced access to preventive care and to acute and chronic disease management. In fact, there are some estimates in the United States that the lack of appropriate cancer screening during the pandemic period may lead to 10,000 preventable deaths due to breast and colorectal cancer in the United States alone. there have been consistent reports of an unfavorable impact in pediatric immunization programs, even in countries where these have reached a successful condition, meaning that immunization coverage in these 2 years will drop in many countries, leading to, of course, unfavorable health outcomes. And apart from that, we can clearly point out that having less access to acute and chronic disease management, both in routine care and emergency care, may also lead to preventable deaths. Let me take an example I'm very familiar with, and this is HIV prevention and care. If we consider this theoretically, COVID-19 impact could reach each one of the steps of the HIV care cascade. It could bring difficulties to prevention in terms of increasing populational vulnerability to HIV acquisition, reduced access to combined prevention measures, condom use, STI diagnosis and care, pre-exposure and post-exposure prophylaxis. It could reduce access to testing and lead to delayed HIV diagnosis. It could lead to reduced linkage to care due to lockdown and urban mobility restrictions, or even to reduced access to services that were shut down for some time under very strict lockdown conditions. It could lead to impairment in sustainable treatment due to risk of medication shortage, reduced antiretroviral prescription and dispensation, to retention in care because of, again, the lockdown and urban mobility restrictions, reduced working hours of services, lack of personnel, and also that may lead to increased losses to follow up. And finally, ultimately, leading to an impaired viral suppression. So again, as was said in terms of life expectancy, bringing down gains that were very hardly, that were obtained with a lot of effort of healthcare teams for the last 2 or 3 decades, with reduced access to ART, loss of social support, worsening of living conditions, and maybe increased loss to follow up. In fact, the impact of COVID-19 on HIV prevention and care is appearing in a number of publications that have been recently summarized in Current Opinion HIV/AIDS, and they include all the different aspects of this continuum of care of the prevention and care cascade I was just talking about. So what is the message we can take from here? We can take a very clear message that action is needed. It is very important to raise awareness of the need to persist in health promotion and adherence to healthcare. Once again, I would like to echo the previous speakers about the importance of reinforcing the importance of the health system, particularly here in Brazil. We have heard that the pandemic raised, let's say, public attention about the importance of our unified health system, but nevertheless, we are still under an underfinanced system. And if we think about possible budget cuts in the next future, it's not very clear for me, Castro, I'm sorry, that we can be that optimistic that just by raising the importance of the health system in the general public opinion, this will effectively lead to a better funding of the system. It's very important to help people return to healthcare, to refer them to healthcare settings where they can have their long COVID conditions taken care of, or other conditions they still need care for. We have to ensure our healthcare settings are safe, using communication and adhering to sanitary measures to prevent transmission of the coronavirus in those settings. And we cannot disregard the need to emphasize the disproportionate impact COVID-19 has had on more vulnerable populations. So our interventions have to bear in mind the need to provide equitable interventions to different populations according to their particular vulnerability, with special attention being given to those more in need. And finally, I think we should go for more creative solutions. We have to make better profit of existing resources, our primary care system, the action of the community, very highly committed community health agents we have in the family health strategy, and try to involve them in identifying patients with long COVID or with other conditions that need care and bring them back to services. We have to take profit of something we used during the peak of the pandemic, the use of technology, telemedicine, which has, I think there is no way back. It was introduced in routine care and it's here to stay, and we should make the better profit of it. And finally, we have to make sure this is a collaborative effort that involves not only public health officers, but also healthcare providers with the participation of the affected communities and their input. I would like to now finalize with the case study of what we are doing in our institution in terms of long COVID. So let me start by saying that this is the Hospital das Clínicas Academic Health Center, affiliated to the School of Medicine of the University of Sao Paulo. In 2020, starting from late March, this largest academic health center in Latin America converted its central institute, where I am talking to you from, into a fully dedicated COVID-19 in-hospital facility, providing 800 beds for the public health system in the city of Sao Paulo. And it is important to say that out of these 800 beds, 300 beds were for intensive care. This was an unprecedented effort of healthcare teams and of the institution itself. It represented a really effective, fast response to the public health emergency in Sao Paulo. It's hard to believe that other institutions would have had the capacity we did to mobilize the community in such a short notice to cope with the pandemic and with the overburden. It was also thought about to have this fully dedicated hospital to maximize favorable health outcomes for patients with severe COVID-19, alongside with trying to reduce cross-contamination to healthcare workers and to patients with other diseases. During this period, so starting from March last year, we have been conducting observational studies using data from inpatients that were admitted to our institution due to moderate or severe COVID-19. 3 very important institutional initiatives were launched. The first of them was to organize an institutional cohort of patients who were admitted to the institution with laboratory confirmed COVID-19 that added up to over 3,000 patients. And we tried to collect standardized data concerning their demographics, their comorbidities, disease aspects, symptoms, lab and imaging results, hospitalization details, mortality, and other incomes. So extracting data from the electronic medical records, this integrated data lake was made available to provide research data for this cohort in different studies. The other initiative that was very important, I would like to emphasize, is the setup of this protocol for multidisciplinary reassessments 6 and 11 months after hospital discharge, and in parallel, the establishment of a BIOS repository with clinical specimens of different kinds that were collected during hospitalization or during follow-up. And all this structure that was put together last year was overseen by a steering committee that was appointed by the School of Medicine Dean and the hospital board. The main differences between our infrastructure and some studies that have been conducted elsewhere with hospitalized patient cohorts is the fact that we have had these in-depth assessments carried out by several specialized teams, in addition to a just yes or no symptom questioning we see in other studies, that we had all eligible subjects invited for in-person visits, so we did not rely only on telemedicine or on telephone interviews, but we had in-person objective assessments, and that we had the possibility of using 2 facilities for this assessment, follow-up assessment. One at the main hospital and the other one at the Heart Institute, which took care of evaluating a large cohort of patients who had been in ICU care. So this is just the study flowchart of this cohort that added up to 3,500 patients. I won't go through every detail, but these are published, and I will then share the reference. One important point about our first follow-up visit is that we had about over 800 attendees, and this is their demographic characteristics. I would like to emphasize that about half of them are Black or brown. So this is a special feature of this cohort that has to do with the population we usually take care of. They are frequently also have other clinical conditions, comorbidities, that may have led to a more severe COVID presentation that required hospitalization. And 65% of this cohort had been under intensive care units, for a duration of 14 days of hospitalization. And 43% of them had been intubated and underwent mechanical ventilation. The main persistent symptoms at first follow-up visit, with a mean of 7 months after hospital discharge, as you can see here, is very widespread in different organs and systems, with the importance, predominance of body pain and fatigue, as well as breathlessness. But it's important to say that about 90% of the cohort referred at least one symptom 7 months after hospital discharge. In terms of emotional and cognitive complaints, I would like to emphasize they were very, very common. 60% of patients had one referred symptom in that domain, and these had to do more often to memory loss or sleep disorder and impaired concentration. Neurologic complaints more often were related to headaches, weakness, speech and walk impairment. We are planning to proceed with this study, trying to identify predictors of long-term outcomes. Here are some of the factors we are exploring: demographics, comorbidities, severeness of COVID during hospitalization, other hospital interventions, and prior frailty to COVID-19 acquisition. And of course, this a better understanding of the scope, magnitude, and risk factors of long COVID will help us establish intervention protocols for these patients at the institution. I would like to finalize by thanking this large number of colleagues that involved a large number of medical specialties who were, I would say, for the very first time, brought together in an institutional effort to cover a public health priority that will have a significant impact in our healthcare provision in the coming years. Thank you very much.
Thank you, Professor Aloysio. Very interesting presentation showing the complexity of the consequences of the long-term COVID for treating the people who survived the disease, but also the other consequences of the pandemic, and how the teaching hospital of USP did a very important job in terms of reorganizing rapidly the capacity to treat the people and following the people, showing how we will need to reorganize healthcare to treat the disease. So actually we have more 30 minutes for discussion. And I would like to invite the people who are watching our panel to make questions. I like to do a very general comment and show some questions for our colleagues, but also I would like to invite for other questions. So it's very interesting to see this our three presentations. The similarities between Brazil and the US in terms of they are the countries that are the most affected in terms of number of deaths and reduction of life expectancy. But as very unequal countries, we had large differences between the population groups. So these similarities tell us about the complexity of our countries and make some implications for our public policies and for our health systems. And I would like to have some comments of the presenters about that. But also we have differences in the two countries. So it's interesting to see that in 2020, US was more affected than 2021. And in Brazil, we had the country, 2020 was much worse than 2021 was much worse than 2020. So I would like to have also some comments about that. We have the change in the government in the US, but also we have the immunization increasing faster in the US than in Brazil. And so interesting to see if there are other consequences on that. I don't know if we have some questions for our colleagues, and then I would like to pass the, I don't know, Marcia, Vera.
I have a question. I have a question. So, so first of all, thank you all so much. This was terrific. And my question is to Aloysio to link with the other talk. So, very specific. Do you have reports in your cohorts that you put together? Do you have reports of long-term disability? For example, people that are now receiving disability pensions because of COVID. And do you have any numbers on mortality, which is what the first two papers discussed? I think there's at least one paper from the UK that reports higher mortality among COVID survivors that had long COVID compared to people from the same age. So those two questions have a direct effect on human capital, right? Which, I mean, the economy should pay more attention when they, try to prioritize economy over health, but also have an impact on what we discussed in the first two papers, which is life expectancy. So do you have any numbers on that from the cohort?
So thank you, Marcia, for the question. This is very important. And when I was listening to Professor Goldman, Professor Tuha, this was something that came to my mind as well. Yes, we do have mortality data in this cohort. I don't have them right now here, but we are collecting data. So patients are scheduled to come for the follow-up visits, and there is active search for those who miss their appointments for a rescheduling of appointments. And from that, we have data of some of them who might have died. And there is a number of patients who are under continuous rehabilitation medicine intervention. I'm not sure if you are familiar with that, but in our Hospital das Clínicas complex, we have one institute. You have already visited it, the Rehabilitation Medicine Institute, which is a very sophisticated institute in terms of rehabilitation medicine interventions they are equipped to provide. And so they are being followed there. And many of these are patients who have not been able to return to work. And we can also collect data about that, because this is really something that shows the socioeconomic impact, because we are talking about family providers who are under sick leave, and I'm not sure if our US colleagues know that, but here in Brazil, if you go under sick leave, your income will be dramatically reduced. So we are already talking about people who sometimes are involved in informal labor market, and out of those who are under formal labor market, if they go for prolonged sick leaves, they will have a significant reduction in their income that will affect not just the provider, but also his or her family. So we do have data on that, Marcia.
Yeah, so I'll follow up with you on that. Full disclosure, I already sent a message on private to Aloysio. We need to talk because I have 1,000 questions. But one thing that I think it's important is really to measure the impact on human capital. And I haven't done this yet, but I already sent a few messages. I'm exchanging a few messages with friends in the Social Security Ministry to see if we see an increase in pensions from disability. And I don't know, Noreen, if this kind of data is available for the US in terms of people going into disability because of the pandemic. And I think we need to pay attention to that, because those are things that may not be immediate, but those are sort of mid and maybe even long-term effects. And, just this morning, Mike Ryan said, we have prolonged impacts in the health system, but it's beyond the health system. It's prolonged effects for society that I haven't seen any, measurements yet. It's not easy to do, but I think we should pay attention to that.
So, any other questions? Or I think Marcia addressed the questions for Loreen, if you want to say some comments.
You're mute, Noreen.
You're mute.
Yeah. So we can at some point get disability claims information. I don't know if we can tie it directly to COVID, and we can tie it to time, right? And we can see what's happened over time, and make inferences about the pandemic. So you raised the interesting question, Adriano, about 2020 versus 2021, and similarities and differences between the US and Brazil. I think what's quite interesting is what the countries had in common, which were anti-science leaders who put the economy above public health, and huge diversity, racial, ethnic, socioeconomic diversity in the populations, which is clearly going to hit some people much more severely than others, even in the absence of vaccine or treatment. It was going to lead to very different exposures to infection and mitigation behaviors. It was also a case where as you say, vaccination came to the forefront under a change of regime. And that's helped the US much earlier than Brazil. Hopefully there'll be a catch-up effect, and the catch-up effect becomes more likely as vaccination stagnates in the US. But the other thing the countries have in common, which I think has been very destructive and not true of all populations, was even under our change of president, we don't quite have a national control to enforce mitigation behaviors, to enforce lockdown, to enforce vaccination nationally before one goes to school or various industries. We have a lot of power in our governors, and that power in our governors, combined with huge political diversity in the two societies, has led to very uneven geographic distributions of infection and mortality and vaccination, and ultimately impacts in life expectancy. And we'll see health, and we'll see disability, and we'll see those long-term social and economic impacts being very heterogeneous across both societies.
I think you should do a study like we did, Noreen, by state. Just saying.
Okay, you brought me into Brazil, and I'll bring you into the US. Start with Louisiana, 30% vaccinated. It's a sad story.
Yeah. Lorena.
So in the morning, and I think all of us, I'm trying to bring a little bit of the perspective, thinking of the communities that are listening to us. And we spent a lot of time this morning talking about the messaging and the implications when we're talking about the pandemic, and how groups read those findings and how groups assimilate those findings. And I'm really struck in the three presentations, and I kind of want to provoke all of you to think a little, I'm interested in thinking about how do we outreach correctly to communities with these findings? Because on the one hand, we can think about there's a very frightening and reinforcing in a very difficult situation that's already very painful, where we've lost many of our people who we know, or we have people who we know are not really feeling well and have long-term symptoms that are undiagnosed, probably because we're still muddling through what is long-term COVID. How do we do effective outreach about these types of findings to engage communities about how to empower them with this? So how do we use this better in our communications? Because I worry sometimes, especially when we talk about, and I listen to these panels, there's a little bit of a feeling of fear, right? I'm at home, I'm trying to stay at home to do the right thing. And at the same time, these findings are saying that the situation is very bad and that I could have something worse because I'm not going to the doctor. And in my community now, I feel devastated, but the findings on life expectancy makes it seem unsurmountable to keep fighting the fight. So I'm wondering if we can talk a little bit about communities and thinking about how do we messaging and what are some of the takeaways if we want to think about NGOs and community organizations that might be listening, and even policy workers that work on social assistance programs. What is the right takeaway for them? I don't know if and it's a hard question. So that's why I spend a lot of time talking, because I know I'm throwing something out there that's a little bit hard.
This pandemic make us a lot of very complex questions. I would like to add a question to Lorraine, to Cássio and Aloysio. First, Cássio, I'd like to know if it's possible to see with the data what are the states in Brazil that have better response to COVID if observing the excess of deaths. Because we have a very different response in the country, as we have a very decentralized system to municipal level. We have 5,500 different responses, but it's possible to see the states that are under a more vulnerable condition, but had capacity to have a better response with observing the data. And for Aloysio, if it's possible with the experiences that you are developing in the clinical hospital of USP, in terms of what are the lessons that we can learn for developing a network of care, including primary care, to long-term impacts of COVID.
Okay, if I may start, I'll try to bring the two perspectives, the one that was raised by Lorena, adding a comment on what Adriano has just said. I think I don't have a final answer for that, but I think a good approach would be the family health strategy program. They are closely linked with communities. At the municipal level, at least here in Sao Paulo, we have a community council that is involved in the establishment and monitoring and assessment of public health policies. So we should bring there the idea that we are talking about comprehensive care. We should not try to disseminate a frightening narrative that people are under threat of becoming severely ill. But I would rather use another approach to say that we have something we can offer these people who have very bravely survived COVID-19, but who are still struggling to come back to their normal lives. Of course, in a health perspective, of course, because the economics has to become better, the labor market has to give them other opportunities. But as far as our sector is concerned, I think we could approach them using NGOs and the population councils at the municipal level and try to build what Adriano has just alluded to, which is this continuum of care. What we see from our cohort, Lorena, is that even though we have a large variety of symptoms that are at least associated potentially with long COVID, most of these patients, they don't require very sophisticated care. They can be dealt with at a primary care level, since we have physiotherapists and psychologists at that in that particular dimension. So we could prepare those multidisciplinary teams with protocol and train them to conduct simple interventions in physical exercise, physical therapy, mental health support that could be dealt, that could, I think, help the health patients cope with most situations. And this would be also the opportunity of let's say, selecting those who need more sophisticated care and having them referred to more sophisticated more highly technological interventions that are available in fewer institutions or healthcare settings. So I'm not sure if I made myself understood, but I would start approaching them under a family health strategy, trying to identify, first of all, people are afraid of speaking up. I'm still not feeling very well. Yeah, so they have to be encouraged to come up and say they need some support, and then have these multidisciplinary teams that include community health workers that visit their households every now and then to identify those who would be invited to participate.
Should I add some points? Yes. So, with respect to Lorena's question, the one that Aloysio just addressed, I think Aloysio is a researcher and is a doctor. So the points he raised are very important because it goes to individuals as well. I'm a demographer, so if thinking with a demographer head, I would say that what's more important. I mean, my presentation at the end, I try to add some hope, right, for the situation. But I guess vaccination would be the answer for would be our best hope, let's say. So, thinking in terms of the population as a whole, of course, that would reduce mortality significantly, and would allow people to work in sectors that have been really have been hit hard, like the service sector, improving the economy, improving jobs, and so on. So that would affect people's lives more directly. So I guess the first answer is to take the vaccine. That would be a demographer saying to people, take the vaccine and ask for the vaccine, and then things will get better. Of course, things will get better. That's what I hope so. And I think there are elements for us to be positive in some sense. If we look at the United States situation now, there's the Delta variant of the virus, but I mean, it's hospitalizing, killing people who did not take the vaccine mostly. So I understand, Noreen can say more about that. I understand that the United States is thinking in terms of maybe taking additional measures, but most of the people who have been hospitalized and who are dying now are those who didn't take the vaccine. So I think there is hope in that sense. Also, Adriano asked about differences in, if you can see any associations between mortality impact and different policies taken by local government. We didn't look at local governments to states, as you know. We in the paper we mentioned, it's hard to, I mean, that's one thing that Marcia and I will also talk a lot, discuss a lot. I mean, in terms of how to establish causal links and associations, correlations. But we mentioned in the paper, if we look at in 2020, the impact was harder for the North than the Northeast states. And both regions have the worst inequality indicators in Brazil, economic, social and economic indicators. So why the Northeast had a better, did better than the North. And one of the hypotheses we raised in the paper was the fact that the governors in the Northeast states, they were they were able to impose physical distancing and other measures better than the northern state governors because they were more in opposition to the federal government. But of course, this is just speculation. We didn't have any casual test to say that did work. I think there's so many. I mean, again, when as I mentioned during my presentation, this is also has to do with the question you raised to Noreen. There was like a kind of a reductionist view when the pandemic started, from some demographers saying that age structure would explain everything. And I guess, unfortunately, the US and Brazil share many difficulties in terms of social and economic conditions that helped the situation to get out of control in our countries, right? The job market, the informal market, the household conditions, and things like that. So, I guess it's pretty clear the fact that the vaccination, as Noreen said, the fact that it started earlier in the US in 2021 than in Brazil, it has had an impact. So that's why, Lorena, I would say to people, get vaccinated, and things will get better.
Great, thank you. I think we have time for more 1 or 2 questions. I think Marcia has a question, Vera also. So
I think Noreen was going to say something.
Yes.
Am I right? Yeah.
Oh, yeah, so I was just going to respond. It's interesting. I'm also a demographer, and I was going to give the response of vaccination. So we share that because I think it directly will impact people's willingness to make greater use of the healthcare system, and it'll reduce the stress and anxiety on the part of health providers to see that. And one short anecdote, I ended very quickly my presentation with this little story of the Native American population with, high morbidity, high mortality, huge distrust of the government for good reasons. I mean, they have been the victim of really inadequate healthcare provision and high rates of disease throughout their history in the United States. Yet they had some of the highest uptake of vaccination rates. I tell the story of one of my closest friends in Canada, where I am now, actually got vaccinations from the Blackfoot Reservation in Montana by crossing the border and not getting out of the car because they had vaccinated 99%, and they were offering Southern Canadians the vaccine. An amazing story. And so what a student looked into, what makes that work? How do they succeed in doing that? And part of the story was the community elders, right? So people who were very trustworthy in the community, had lots of respect, not coming from national TV or something of the sort, but, the importance of local trust and communication to get people, despite, huge concerns about something the nation was touting that they take, were willing to get that. And that tells me that, that's going to be hard, right? And we don't have the community healthcare structure to the degree you have it in Brazil. But I think that's where our hope lies in getting people to get vaccinated and to hear the messages about mental health. One of my greatest worries of the pandemic, which is vastly underprovided in the US, and I imagine also in Brazil, and has had a huge negative impact through COVID.
Yeah, and it's interesting because this morning, Mike Ryan said, we have plenty of information. What we lack is trust. So, in talking about infodemic. So, so I had asked the question before. So why don't we let Vera ask a question, because she hasn't spoken yet.
No,
You pass. Okay. So here's a question. So the US made the census in the middle of a pandemic. Brazil has not made the census. We don't even know when we're going to have a census. So forget about getting right denominators for anything. The data Aloysio presented just made me ask a question if in the future we're going to need a special cash transfer for people with long COVID, like we had a special cash transfer for mothers that had babies with congenital Zika syndrome, another epidemic, not a pandemic, that we had. But to be able to even figure out if we have this demand, we need data. So what I would love to hear Noreen's reflection on the census we had in the US and all the debates that happened. Put the question, ask the question about migration status, don't ask the question, change the census, but then the president changed. I don't even know what's happening now. And I would love to hear Cassio's reaction on the fact that we are completely in the dark about denominator. So how do we even move forward in making any decisions in the dark? So I'll start with Noreen.
Okay. So that's a good question. I don't quite know what's the status of our census. I mean, numbers aren't released, but what scares me, two things scared me. One is the pandemic that occurred during it. The other is, in the end, there wasn't a citizenship requirement, but there was tremendous talk during the Trump era, about that, right? And, whether a question, not a requirement, a question on the census form regarding citizenship that probably had huge numbers of undocumented, very frightened about taking the census. Again, that ultimately didn't go through, but last minute changes, communication is bad, communication's worse during the pandemic. And I fear it will have led to the undercounts of the most vulnerable, which will have all sorts of political ramifications, both in terms of Congress and in terms of funding.
Yes.
Well, I think the issues of the Brazilian census, the roots of the issues come back to when polarization in Brazil started to get tougher. So back in 2018, 2019, and so on. Now, when the census, we were just 1 year before the census to happen, and then were all the fights because of the questionnaire and so on. And these things started in the academic community, and then they spread out. Journalists were following the discussion, things went out of control and so on. And then came the pandemic. And then I guess in 2020, everybody agreed that it would be hard for Brazil to collect the data. In a way, I didn't see too much fight on that. But then 2021, there's a lot of fight. And then the polarization came again and people were discussing and so on. I guess the census, I'm part of the 2020 census committee in BGE. I'm very confident that the census is going to get collected next year. But it's too bad that we didn't have the counts, for example, to help us define the target populations for the vaccination. So there was one study I've been working where we show that the health authorities needed to use population projections and population projections based on the 2010 census. And so it's two-way in the past. There are all the problems related to how to project mortality, and all the uncertainty related to projecting population at the local levels, because the IBGE does not provide projections at the municipal levels, only at state level. So each state has to deal with this estimates for small cities and so on. There's a lot of uncertainty, particularly for the elderly. So I guess we are paying the consequence of not having the census. But now it's too late.
Yeah.
We have to wait for next year. And I really hope the next year you're gonna get the data.
Yeah, I think this is an important discussion because information is power. Right? I mean, in the US, we still have some states that we don't have data on COVID mortality by race and ethnicity, right, Noreen? I don't think all of them release, at least in the beginning, they didn't. We have estimates, but not sure.
Yeah, I think we now have more complete information, although it's always suspect. Right? I mean,
yeah. And in the case of Brazil, it's interesting because on the history of our census, it was during the military regime, the only time we didn't have the question on race and ethnicity. That's not by chance. There is a reason that the question was suppressed in the middle of the military regime. And again, France still does a census without a question on race and ethnicity. So if you don't measure, you can say you don't have an issue. But that's for our next keynote. David Williams is already here. So we're going to talk about racial issues and on COVID. So Cassio,
I know the time is up, but just to say
go ahead.
That on the other hand, we had problems with the denominators and the population counts, but on the other hand, it's incredible to see how much Brazil was able to gather data. You know, the effort that the universities and the local governments have everyone made to build this new database, you know, including the vaccination registration system. I even said to the current president of the IBGE, who's a demographer, our friend Eduardo Neto, former student of Noringold, that I mentioned to him that he should use, and he was, use the vaccination system record to help the census next year, you know, with all the problems that the records have, you know, it's new data being produced as the pandemic goes on. So this is incredible.
No, in terms of data, Brazil is like 10, US is 0. I mean, there's no question about it. I mean, I'm sorry, Noreen and David, but it's really 10-0. And I talk about soccer all the time, but it's 10-0.
Last comment. I think almost no country collects data on race and ethnicity in the census. I think the US and Brazil are among the rare exceptions that collect those kinds of data.
Yeah.
Okay.
So
thank you so much in the name of the Institute of Advanced Studies and USP for your contribution, exciting discussion, right? I was hoping to see Professor David Williams. There's a lot of people, we're very excited to hear you in Brazil right now, right? And so welcome to our panel. And Marcia is going to lead.
Yeah,
so thank you, Marcia.
All right, so thanks again, Noreen, Cássio, Adriano, and Aloysio.
Yes,
this was exciting. To be continued, folks, because I think we raised so many questions. So thank you so much. So now we move to our keynote in the afternoon. And I am really glad to introduce Professor David Williams, my colleague in the School of Public Health. He's the Norman Professor of Public Health and Chair of the Department of Social and Behavior Sciences. He's also a professor of African and African Studies, African American Studies at Harvard. And he has written so many, I'm not going to read everything from his bio, but he's widely published. He's a member of the National Academy of Medicine, the American Academy of Arts and Sciences, and the National Academy of Sciences. He has been ranked as the most cited Black scholar in social sciences worldwide and as one of the world's most influential scientific minds. David, the moment we had this topic, I knew I needed to have you in this panel. Thank you so much for dedicating some of your busy schedule to talk to us about racial issues and COVID. So the Zoom is yours, David. Thanks so much.
Thank you so much, Professor Castro, my dear colleague and friend Marcia. It's truly a privilege to be here with you. Brazil is one of my favorite spots on the planet. I've visited Brazil about 5 times, and sorry that I'm not there in person, although COVID is not maybe the best time with what's happening here and there to travel. But it's an honor and privilege to join you today and to talk about some of the research of racial inequities in health and the way COVID illustrated that. And I also want to put the US data in the context and show some patterns where I have data in the United Kingdom as well. One of the things that sometimes happens even to people who study race and health in the United States, we think the patterns are distinctive, but as you look across countries in societies that what I would call are racialized, where there's a ranking on some basis of physical external appearance, we see similar patterns, and I hope we will see that in my talk today, looking at the UK and the US. I'm going to share my screen so that you can see my slides. 1 second, I need to pull my slides back up. Because I don't see them at the moment. Let me, okay. I'm gonna go back now. I should have them. Yes, here we are. All right. All right, so race and COVID mortality is the general topic that I have today, and I want to begin with data. So this is the best data. It's not perfect, but it's the best data we have, and it's deaths through March 2 of 2021, and it shows the age-adjusted odds ratios. And it looks, compared to the white population as one, what are the death rates for other groups? And you could see the Pacific Islander population, the Black population, the Latino population, and the Indigenous or Native American or American Indian population, all those terms will be used interchangeably. All of them have death rates that are much higher than that of the whites, more than twice as high, with the Native Americans, although a relatively small number, having the most elevated risk. The pattern for the Asian population is similar to that of the white population, although there's heterogeneity within the Asian population, and there are some groups that did more poorly than others. The other point is that sometimes when we talk about death rates that differ by race ethnicity, there are people who confuse that with the number of people who have died. So here I am showing you the number of persons who died from COVID through March 2, 2021. And at that time, this is about 520,000 deaths. It's much more than that now. And you could see the vast majority of deaths, it's almost 300,000 is the white population, and 18,000 for the Asian population, about 73,000 for the Black population, almost 90,000 for the Latino or Hispanic population, and 5,477 for the Native American or Indigenous population. So it's just important. I know I've encountered white people who thought that white people are not at risk of dying for COVID because it's just the minorities who were dying, and not realizing that there are differences in the risk of death, but this pandemic had a negative impact on all populations. Here is data on COVID-19 mortality in the United Kingdom compared for the disadvantaged racial populations compared to the white population. And here are the age-adjusted odds ratios. And you could see for Black males in the UK, the death rate was 4.2 times higher, so even larger than the US. For Bangladeshi, Pakistani, that's a disadvantaged group in the UK, 3.6 times higher. For Indians, 2.4 times higher. And for females, you see a very similar pattern, 4 times bigger for the Black females, 3.4 times for Bangladeshi, Pakistani, 2.7 times for Indian. That is a striking pattern. What is particularly striking to it from observers from the US and even for the UK, this was a shock to, I was called to speak to a number of meetings in England about trying to make sense of the data. And the difference is, in the United Kingdom, everyone has access to medical care. In the United States, that is not true. And disadvantaged racial populations do not have good access to medical care. So here is in a context where, in theory, everyone has good access to medical care, we still see striking racial differences. In fact, these initial racial differences in the United Kingdom were even larger than those in the US. I'll come back to what might be the drivers of these differences. But let me go back to the US context. This was a report that came out about 6 months ago. There are other reports more recently that confirm these findings. The racial disparities in health in the US from COVID has had a large impact on life expectancy at birth. Life expectancy at birth in the United States for 2020 compared to 2019 declined by more than a year overall. And then when we look within subpopulations, you could see a 3-year decline for Black males, 2.4 years for Hispanic males, 2.3 years for Black females, 1.1 year for Hispanic females, 0.8 of a year for white males, and 0.7 of a year for white females. One recent report talking about this gap decline in life expectancy, the gap from 2019 to 2020, the decline in 2020, we have not seen such a large decline in life expectancy in the US for 70 years. So this is a huge negative impact on the population overall, but you can see disproportionately it affected the economically disadvantaged populations. So the big question that we need to struggle with today is why? What drives these large racial inequities in health? My first thought would be there are large inequities in health by socioeconomic status, SES. That's in the US and elsewhere. And when I use the term socioeconomic status, I'm talking about income or education or occupational status or wealth. Around the world, these factors, income and education, for example, are large predictors of variations in health. And in the US and the UK, there are large racial ethnic differences in socioeconomic status. So here is national data for the US for 2018. And I am presenting them in a way where I'm standardizing on the household income of whites as $1. So for every dollar of household income white households receive, Asian households receive $1.23. Several caveats. The Asian category has more persons in multi-generational households. So there are more persons contributing to household income in the Asian category. So if the data was presented as a per capita or a per person measure of income, whites would have the highest income. But it's also important to remember that almost 70% of Asians in the United States are immigrants. They are a population that have come to the US with high levels of education. They have markedly higher levels of education than the white population. So a higher level of income is not surprising given the high levels of education. But let's look at the historically disadvantaged groups. For every dollar of household income white households receive, Hispanic or Latino households receive 73 cents, and American Indian or Black households receive 59 cents. What is really surprising, I would say even stunning, about the 59 cents figure for Blacks is, and this is 2018, that is identical to the Black-white gap in income in 1978. I did not misspeak, you heard me correctly. I said 1978. And why did I pick 78? 1978 was the peak year of the narrowing of the Black-white gap in income in the United States as a result of the anti-poverty policies of the 60s and 70s and the civil rights policies of the 60s and 70s. The gap had been narrowed in 78 to 59 cents. And in 2018, the gap is still 59 cents to the dollar. Has the gap been unchanged over time? Oh no, it got a lot worse from 1978. It fell throughout the decade of the 1980s. That was a decade of Ronald Reagan, was not good to the Black community. It fell as low as 54 cents to the dollar in the 1980s. And it wasn't until the mid-1990s during the President Clinton era that it came back up to 59 cents. And it's been a penny up and down from that. Sometimes it's 58, sometimes it's 59, sometimes it gets to 60. But the point is, surprising to where most Americans think. Most Americans think that America had a race problem, and Martin Luther King and the civil rights movement, the race problem was solved and there are no racial inequities. And I'm showing you for one group where we have good data going back decades, the racial gap in income in 2018 is exactly where it was in 1978. So there are much larger racial inequities in income than most Americans think. If we look at data for the UK, and I've tried to present data similarly, for every pound, the currency of weekly income the white majority earns, other whites, that's mainly Eastern European, whites from Eastern Europe, earn 79 pence, Indians earn 86 pence, Pakistanis 57p, Bangladeshis 52p, Chinese 76p, blacks from the Caribbean 77, blacks from Africa 60 pence. So the groups that I focused on earlier, blacks, the two black groups, as well as the Pakistani, Bangladeshis, and Indians, also have lower levels of income than the white population in England. Now, as striking as the data on income show, I would argue that it dramatically understate the racial gap in economic status. What do I mean by that? Well, income captures the flow of resources into the household, wages and salary, but they tell us nothing about wealth, about the economic reserves, of the financial assets, of the home equity, of the money in the bank, of the investments that individuals have. And wealth gives us something about the economic reserves that individuals have to cushion shortfalls of income. And here is national data on wealth from the Federal Reserve Board in the United States. And it shows for every dollar of wealth that white households have, black households have only 10 cents, and Latino households have 12 cents. So there are very, very large gaps in wealth in the US. In the United Kingdom, we see a similar pattern. Here is median wealth by ethnic group. And again, for every pound of wealth the white British have, Indians are close, 95 pence, but Pakistanis, 50 pence, blacks from the Caribbean, 20 pence, blacks from Africa, and the difference is the blacks from the Caribbean on average arrived earlier and are more likely to own their homes in England than blacks from Africa, who are more recent immigrants, and housing prices in England makes it difficult for them to own homes, only 10 pence, and black Bangladeshis 10 pence. So what I've shown you across two societies, there are large racial gaps in health, but there are also large racial gaps in income and in wealth. What low economic status means is that although we are in the storm of the pandemic, we are in different boats. When a household does not have wealth, does not have any savings, does not have any economic reserves, they are less able to feed the family, to pay their rent. So in the context of the pandemic, some boats are better able to weather the storm than others when you have economic reserves. When my career started, most researchers thought that racial differences in health were simply a function of racial differences in income and education. And if, for example, in the United States, we looked at blacks and whites at the same level of income and education, the expectation was there would not be any differences by race. We now know life is more complicated. And I want to illustrate that with life expectancy at age 25 data. This is national data for the United States. Life expectancy at age 25. So at age 25, how long will the average person live? The average white person will live 5 years longer than the average black person at age 25. Now, let's see what happens when we look at the difference by education. We can see that whites with a college degree or more education in the United States live 6.4 years longer than a white person who has not finished high school. So by education within whites, we see an even bigger gap than the racial gap. And within blacks, by education, the best of blacks live 5.3 years longer than the blacks with the lowest level of education. So this is really an important point. And this is true for most health outcomes in the United States, although we tend to report data in America simply by race and not by race and economic status at the same time, which is what I and others have recommended should be done for decades. Because it's not either or. I want to illustrate the power of looking at data by income and race, or education and race at the same time. In the interest of time, I'm showing you just the data by education and race, but by income, you see the same pattern. What you find, although there's a large gap by education within whites and within blacks, at every level of education, race still matters. So whites who have not finished high school live 3.1 years longer than blacks who have not finished high school. And the gap actually widens, which surprises people. Most people would expect the gap to narrow as education increases, but as education increases, it widens. And this is national data for the United States. And you see this stunning example. The best of blacks in America, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who have finished high school. So what are these data telling us? There's something about income and education that matters for your health regardless of your race. But there's something else about race that matters even after we take income and education into account. And just to show you the pattern is similar for the UK, here is data I showed you before. Here for men is the age-adjusted data. And in the UK, the data is adjusted for even a broader range of variables here, adjusted for income, for education, for household type, for health status. And even after adjusted for all of these factors, multiple indicators of economic status, black men still have an odds ratio almost twice as high as those of whites. And you can see for Bangladeshi 1.8 times, for Indians 1.3 times. And if we look among females in the UK, here was the age-adjusted data, and it's still almost twice as high for black females after we've taken multiple indicators of demographic status and socioeconomic status into account, and 1.6 times for Bangladeshi females, 1.4 times. So in both societies, we are saying, even after we've taken the standard measures of economic status into account, we are still finding a residual effect of race. And so researchers have been asking, why does race still matter so much? And specifically, could racism be a critical missing piece of the puzzle to understand the patterning of racial disparities in health? When I use the term racism, what do I mean? I think of racism as a social system, not so much the beliefs and behavior of individuals, but a social system. You can see the arrow goes both ways. It has shaped, and it is shaped by larger political, legal, economic, religious, cultural forces, and historical events. So I define racism as an organized system. It categorizes and ranks populations. It devalues some and disempowers some. And it differentially allocates opportunities and resources to populations. Central to racism is an ideology of inferiority, that some groups are inherently better off than others. That is the justification for the devaluing and disempowering of some groups. Yes, racism can lead to the development of negative attitudes and beliefs, prejudice and stereotypes, and differential treatment, discrimination that can take place by individuals and social institutions. But fundamentally, we need to understand, I think of racism as a system, and the system has ripple effects at multiple levels of society. I want to talk about the ways in which racism affects health and some of the empirical evidence we have for a role of racism. So first, I want to talk about one mechanism of racism that is the term structural or institutional racism is widely used to capture that. And I want to illustrate that with US data using residential segregation as the example. Residential segregation was a policy that emerged in the US in the late 19th century. It was strengthened in the early 20th century, was very well locked in place by the 1940s, and has been illegal in the mid-1960s, but the structure put in place still persists. And basically, where you could live was linked to your race. Your race determined where you were allowed to live. John Sell was a historian at Duke University in America. He wrote a book about the origins of segregation in the US South and South Africa. He showed that the framers of apartheid in South Africa looked across the Atlantic and saw residential segregation in America and how well it was working in the late 19th and early 20th century and said, brilliant, we can implement that in our country. Importantly, Sell argues that residential segregation was one of the most successful domestic policies of the 20th century in America. And you would say, well, why would place matter so much? Well, this is how I think of segregation. I think of segregation as a burglar that enters a community at midnight. It slips into the community, doesn't wake up anyone, but once it shows up, valuables disappear. So in highly segregated, disadvantaged communities, valuables that disappear is quality schools and safe playgrounds and good jobs and a healthy environment and safe housing and good quality transportation and even access to high quality medical care. All of these are factors that research shows in the US vary by race. I want to give you some empirical studies. These are two sociologists at Harvard University, William Julius Wilson and Robert Sampson. They did an analysis of the 171 largest cities in the US. And they said there's not even one city where whites live in equal conditions to those of blacks. And they concluded that the worst urban context in which whites reside is considerably better than the average context of black communities. So segregation has really produced neighborhood conditions that vary dramatically by race. Now, you might note that's a 1995 study, so you say, Professor Williams, how have things changed? So here's another wonderful colleague of mine, Professor Dolores Acevedo Garcia. She's a professor at Brandeis University. She created an amazing database. It's called the Neighborhood Opportunity Index. She's ranked every county in the United States and most census tracts on 28 different indicators of access to opportunity. Her focus is on children, but access to opportunity for children reflects access to opportunity for the entire community. I want to give you examples of the indicators. I don't have all 28 listed here, but the quality of schools and the quality of early childhood centers and the high school graduation rate and the percent of individuals in high school jobs and the income level and the home ownership rate in the community and the quality of the air and the water and soil pollution and access to resources for health like green space and access to fresh fruits and vegetables and safe places to walk. So it's 28 different indicators of access to opportunity. And this is what she found. And this is a 2020 publication. If you look at the 100 largest metropolitan areas in the United States, 67%, 2/3 of all black children are living in very low and low opportunity neighborhoods. That's true of 58% of Hispanic kids and 53% of American Indian kids. In contrast, only 1 in 5 white and Asian kids live in very low and low opportunity neighborhoods. If we look at the opposite end of the spectrum, who is residing in high and very high opportunity neighborhoods, you see almost 2/3 of all white children and almost 2/3 of all Asian children live in high and very high opportunity neighborhoods. So what does this tell us? Is that access to opportunity at the neighborhood level varies dramatically by place and by race in the United States. More data. I'll show you 2 more studies by Harvard economists that shows that segregation, access to opportunity at the neighborhood level, is actually the driver of why racial differences in income and education exist in the first place. So first, I'll look at the work of David Cutler. He's an economist at Harvard University. He did a national study of blacks and whites in the United States. And statistically, he shows if you could eliminate residential segregation, you would actually completely eliminate or erase black-white differences in income, in education and in unemployment, and reduce racial differences in single motherhood by 2/3. In other words, if you step back to ask, why are there large racial differences in income, in education, and unemployment? Why have they persisted over time? Well, it's linked to opportunity at a neighborhood level, and if those opportunities haven't changed over time, you see the persistence of those racial inequalities. One last example of economic data that points to the power of segregation. Another Harvard economist by the name of Raj Chetty, he has done an amazing analysis. Using census data from 1989 to 2015, he asked an intergenerational question. Let's look at Black and white children who start out life at the same place. Their households are similar in terms of their parental income. How are the children doing in the next generation? And he finds that in 99% of census tracts in America, census tracts is a geographic unit with, several thousand, a few thousand people. In 99% of census tracts in America, Black boys have lower earnings than white boys, even after taking parental income into account. Why? They live in neighborhoods that differ in access to opportunity. Do we have a similar pattern in the UK? Not quite. There are some similarities, but the histories are a little different. Scholars who study segregation, like Doug Massey, shows that levels of segregation in Europe are increasing while they are declining in the United States. They also show something intriguing, that in Europe, Western Europe, segregation is stronger, slightly greater by religion. So Muslims are more segregated than non-Muslims. And secondly, by skin color. So religion trumps skin color in the UK context. So here is the levels of segregation. This is the index of dissimilarity. Generally speaking, a score of 60 or higher is regarded as a high level of segregation, and a score of 61 for Bangladeshis would mean that 61% of Bangladeshis in Britain would have to move to have an even kind of distribution of Bangladeshis and whites in the UK. And you can see segregation levels also high for Pakistanis, a little lower for Indians, and even lower for Caribbean blacks, confirming the point that Massey shows. It's religion is a major basis for segregation in addition to race. At the same time, other data from the UK, although the mechanisms may not only be segregation, other data for England suggests that the disadvantaged racial populations are overrepresented in the most deprived neighborhoods. So here's national data on who is living in the most deprived 10% of all neighborhoods. So this is the worst of 10%. If the levels were equivalent across populations, you'd find whites, 10% would live in those areas. Instead, you see Pakistanis, 31% of Pakistanis live in the worst 10% of neighborhoods, 28% of Bangladeshis, 20% of blacks from Africa, 18% of blacks from the Caribbean, 19% of Arabs. So we are also seeing in the UK an overrepresentation of disadvantaged populations in the most deprived residential areas. An important take-home message is that the racial inequities in socioeconomic status that matter for life and health, sometimes people talk about the fact we have a broken system. And my argument is, no, we do not have a broken system. We actually are looking at the implementation of social policy, a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in racism. So the racial inequities we see are not accidents or acts of God. They reflect the successful implementation of social policy and what I'm calling a truly rigged system that it has produced in the United States. Segregation has another impact on health. And that another pathway, in addition to what I talked about at the neighborhood level and access to opportunity and income and education, research, mine and that of others in the US, shows that when an individual lives in a disadvantaged, segregated neighborhood, and they are also lower in economic status, they are exposed to higher levels of economic stressors, that is, like facing unemployment or being unable to make ends meet at the end of the month. Psychosocial stressors like unemployment or the death of a loved one. Physical and chemical stressors like exposure to air pollution. So that segregation, another mechanism by which it affects health, is by shaping exposure to both psychosocial and physical chemical stressors. So I've talked about structural institutional racism, segregation. I want to touch base briefly on individual discrimination and its consequences for health. And I would argue, I just talked about stress. One source of stressful life experience that historically we haven't studied, but there's been a lot of study, I would say, in the last 25 years, is the stress of discrimination. And here is one measure. I developed a number of measures to capture discrimination. One of them is called the Everyday Discrimination Scale. It doesn't capture all aspects of discrimination, but just little day-to-day indignities. Being treated with less courtesy and less respect, receiving poorer service than others. People acting as if they think you are not smart, or if they're afraid of you, or if they think you are dishonest, or they're better than you are. Little indignities on a day-to-day basis. I want to show you the power of this measure. There have now been more than 400 published studies globally looking at everyday discrimination. There are actually studies from Brazil that have used the Everyday Discrimination Scale. And these studies find that high levels of everyday discrimination is linked to a broad range of health outcomes. I just want to give you some examples. There are studies that show that new cases of metabolic syndrome, of cardiovascular disease, of breast cancer, of type 2 diabetes is linked to high levels of everyday discrimination. High levels of everyday discrimination also lead to higher levels of engagement in risk behaviors that adversely impact health. High levels of everyday discrimination is linked to multiple markers of subclinical heart disease, like coronary artery calcification, or visceral fat, or heart rate variation, or atrial fibrillation. Higher levels of everyday discrimination also predicts higher levels of blood pressure and asthma. Higher levels of discrimination predicts poorer sleep, quantity and quality. Higher levels of everyday discrimination predicts systemic biological dysregulation, higher levels of inflammation, higher levels of cortisol, shorter telomere length, higher levels of allostatic load, which is a measure of biological dysregulation across multiple systems. Higher levels of everyday discrimination predicts obesity and even weight gain over time in prospective studies. Higher levels of everyday discrimination instructively predicts less engagement with healthcare and less follow-through on a healthcare provider's recommendations. And finally, higher levels of discrimination predicts higher levels of mental disorders, as well as measures of depressive symptoms, anxiety symptoms, and emotional distress, and so on. So just this slide is just illustrating the multiple ways in which research is documenting discrimination adversely impacts health. Today, we now have studies from Australia, New Zealand, South Africa, the United Kingdom, and the US that shows when you look at racial differences in health and you statistically adjust for income and education, but there still is a residual effect of race. That effect is further reduced when you add a measure of interpersonal discrimination to the statistical model. So we now are documenting that discrimination, the interpersonal discrimination, is making an incremental contribution. And this is not just studies of everyday discrimination. It's only one measure. There are multiple measures out there that are being used. I also want to point to that there are hidden ways in which stressors linked to race and racism adversely affect health. So here is a study I did with a young scholar many years ago. It was the first study that looked at discrimination online among middle and high school students in the United States. And we found that the experiences they had in an online context where they were treated badly because of their race was linked to increased depression and anxiety symptoms even after we statistically adjusted for discrimination offline and a global measure of adolescent stress. So we documented that the online discrimination was impacting their mental health over and above other stresses they face. That same colleague, Dr. Brandisha Tynes, recently published a paper looking at Black and Latinx adolescents, 11 to 19 years old, and found that if they've more frequently viewed images or videos of someone of their racial group being beaten by the police, being arrested or detained by the police, or being shot by the police, exposure to these online traumas predicted higher levels of post-traumatic stress disorder, PTSD, and depressive symptoms. So we are seeing among these young people that just these online exposures of someone from their group harmed by the police is adversely impacting their mental health. Here is another study I did with one of my former students, and we looked at national data for the United States. We used a database for 3 years that looked at every police shooting in America, and then we linked it to state-level data for multiple states from the CDC on the mental health of the population. And using a quasi-experimental design, we were able to show that every police shooting of an unarmed Black male led to declines in mental health, not just for the family and friends, but for the entire Black population in the state in which that shooting occurred for the next 3 months. So documenting a negative effect of police shootings on the mental health of populations. What's the consequence of this? Scholars are using the term that all this stress is leading to accelerated aging or premature aging or biological weathering and the earlier onset of chronic disease. What do they mean by the fancy terms? Let me use the biological weathering. Imagine a drop of water falling from the rooftop of the building you are sitting in to the concrete sidewalk below. If water dripped today, it's not a problem. But if day in, day out, week in, week out, month in, month out, there's a steady drip, drip, drip of water, the sidewalk below would become weathered. It would become eroded by the constant exposure to adversity. And what the research is suggesting that in the United States, Blacks and Latinos and Native Americans, as populations that are studied, they are literally aging biologically more rapidly than that of whites. And so the term that Arlene Geronimus uses is weathering, but it's talking about a cumulative negative impact of repeated exposure to psychological, social, physical, economic, chemical stressors. And that these stressors are taking a toll and are leading populations to age biologically. There are studies that use telomere length that shows racial differences, 7.5-year differences between Blacks and whites of the same chronological age. Because what this is saying is that your age is not only telling us how long you have lived, your age is also telling us how long you've been exposed to bad environmental conditions and how physiologically compromised you have become as a result of those exposures. And so a consequence of that, and I'm illustrating it with data just on high blood pressure, is that you can see age 50 to 64, but at every age, but let's look at 50 to 64, 61% of all Blacks 50 to 64 have high blood pressure in the United States compared to 41% of whites. So you see the earlier onset of disease, and what's true for high blood pressure is true for kidney disease, it's true for a stroke, for diabetes, it's true for a broad range of conditions. Why does this matter? Let's come back to COVID-19. This is a study of 12 hospitals in New York City early in the pandemic. And what this study looked at, almost 6,000 patients, is the percentage of them that had a comorbid condition. So you could see of people hospitalized in these 12 hospitals in New York, almost 6,000 people, 57% had high blood pressure, 42% were obese, 34% diabetes, 18% with heart disease, and so on. In fact, only 6% of persons hospitalized for COVID-19 had no comorbidity, and only 6% had one. So 88%, almost everybody, had two or more. And what am I saying? I'm saying one of the reasons for the higher rates of death from COVID-19 of populations is the higher rates of comorbidities that reflect the accumulation of the living and working conditions that lead to higher levels of stress, and that literally have, with these comorbidities, puts these populations at higher risk. So I've talked about racism. I've talked about the structural institutional racism. I've talked about the stress of interpersonal discrimination. Quickly, I want to talk about cultural racism and just give one example quickly of how it operates, the negative stereotypes in our culture. It leads to inequalities in medical care. This was a report from the government back in 2003 on equal treatment from the government requested of the National Academy of Medicine that documented that Blacks and other minorities receive poorer quality care than whites. Just to give you one example of the studies that this report was based on, Dr. Todd was an emergency room physician at UCLA, emergency department, and he asked a simple question. When a patient comes to the emergency department with a broken bone in the arm or leg, does the patient's ethnicity determine whether the patient gets pain medication or not? So he looked at everybody for 1 year treated in the emergency department at UCLA, and he found that 55% of Hispanic patients with a broken bone in the arm or leg got no pain medication compared to 26% of whites. And when statistically he adjusted for every potential confounding factor, the single biggest predictor of whether a patient got pain medication or not was whether the patient was Hispanic or not. He replicated the same study in Atlanta with Black and white patients, finding Black patients with a broken bone in the arm or leg less likely to get pain medication. One other quick study just to make the point. A study of 1.8 million hospital births in Florida between 1992 to 2015. When cared for by white doctors, Black babies are 3 times more likely than white newborns to die in the hospital. This disparity is cut in half when Black babies are cared for by a Black doctor. One of the things this highlights is the importance of diversifying the workforce to meet the needs of all patients. I want to show you the power of having racial concordance. This is a randomized controlled trial of 1,300 Black men in Northern California. They were recruited from barbershops and the community, sent to a Saturday clinic, randomized to be treated by a Black doctor, someone of the same race, or a doctor of a different race. The study found that men who saw a Black doctor were more likely to talk about other health problems, more likely to do screening for diabetes, more likely to accept the flu vaccine, more likely to do screening for cholesterol. So there was much better engagement and utilization of services when there was a match in racial concordance. In the United States, we face a huge problem. In 2014, there were 27 fewer African-American males in the first year of medical school than in 1978. In fact, in the mid-1960s, 2.9% of all practicing physicians in America were Black. In 2019, 5%. So there's an increase, but it's a small increase. 5% of practicing physicians are Black, only 6% are Hispanic, and only 0.3% are Indigenous or Native American. So we have a long ways to go. There is some good news. The good news is, here is a study of cultural competence among patients with HIV/AIDS, and they found large racial disparities. However, there were no racial disparities regardless of the race of the clinician if the clinician scored high on cultural competence. I want to give you some of the items on the cultural competence scale. A physician who scored high in cultural competence is a physician who said family and friends are as important to health as doctors. A physician who said social history contributes to how I care for my patients. Someone who said, I'm familiar with the lay beliefs my patients have. So I asked them about their lay beliefs. I asked my patients about alternative therapies they use. I find out what my patients think is the cause of their illness. I involve patients in decisions about their healthcare. So it suggests that a healthcare provider who respects their patients, engages with them, talks to them, gets their ideas and their understanding, and has a useful dialogue, that disparities can be reduced under those conditions. So I've talked about racism, multiple mechanisms by which it produces inequities in health, but in other social statuses. And I'm also saying that these inequities reinforce the stereotypes and the biases that exist and go back to strengthen the system of racism in the first place. I've talked about what needs to be done within medical care. Quickly, I want to talk about, as I come to a close, the big issue is how we dismantle the segregation and the inequalities that were created in the first place. I call for the need to create communities of opportunity to minimize, neutralize, and dismantle the systems of racism that create inequities in health. In other words, to improve health and racial differences in health, we need to enrich the quality of neighborhood environments. We need to provide for economic development in poor areas. We need to include housing quality and the safety of neighborhood environments. What would communities of opportunity look like? We need to invest in early childhood programs, reduce childhood poverty, enhance income and employment opportunities, improve neighborhood and housing conditions, enhance economic opportunities, raise awareness levels of these problems. There's high quality evidence, I don't have time to review them, that in providing additional income with no health intervention, we have randomized controlled trials, shows among poor populations, you get improved health even with no health intervention. I want to talk about one example in the US of neighborhood intervention. It's called purpose-built communities. And I cite it not because it's perfect, but because it shows it can be done. Many policymakers I talk to think the problem is so complex, it's so complicated, there's nothing we can do about it. So come with me to East Lakes Meadows, Atlanta in 1995. It's a public housing project where there's a huge crime rate, 18 times the national crime rate. 90% of families are victims of crime every year. It's poor public housing, many units unlivable. Only 13% of adults are employed. The elementary school is one of the worst performing in the state of Georgia. And what happened in Purpose Built? They came together with the community, the public housing department, and a wealthy philanthropist, and they tore down the public housing project and built anew the villages of East Lake. 50% of the people living in the village of East Lake qualify for public housing, 50% are at market rate. There's been a 90% reduction in violent crime. The high quality mixed income housing. All able-bodied persons are employed. And the school, elementary school, is one of the best performing in the state of Georgia, even though 60% of the students qualify for reduced price lunch. That means 60% of them are coming from poor households, but yet the school is one of the highest performing, one of the top 5 in the state every year. It shows it can be done. We can address all of the challenges faced by poor communities simultaneously. We can develop place-based solutions. We can improve housing and provide the services to improve the quality of life and housing. What do we need to do to while we wait for all the great solutions? Let me talk about some evidence of individual and community resources that are resilience factors. So first of all, here is a study from Georgia. Teenagers, Black teenagers, aged 16, 17, and 18, they were studied. Those who were high on discrimination at 16, 17, and 18, by age 20, they had higher levels of stress hormones, cortisol, epinephrine, norepinephrine, higher levels of blood pressure, of inflammation, and of BMI at age 20. However, that relationship between discrimination And the biological dysregulation is broken if they were high on social support, high levels of support from their family, their friends, their teachers, documenting the protective role of high quality social resources. Here is another study, national data for the US among Black Americans. Those who were high on religious involvement, religious attendance, church-based social support, seeking religious guidance, it reduced the negative effects of the stress of discrimination on mental health. So again, social ties as a positive resource, religious engagement for religious individuals as a positive resource. And final example I want to give you is from Canada, First Nations or the indigenous population in Canada. This is a population that had very high rates of youth suicides. Researchers went to study this group. Here is communities with high rates of youth suicides, and they studied 196 of these communities. As a group, they have high rates of suicide, but the researchers found that more than half of them had had no suicides at all over a 5-year period. And so they wondered what distinguishes those communities with high rates of suicides from those that didn't have high rates of suicides. And they found 5 markers of communities that were challenging the federal government over titles to land, over the right to self-governance, over controlling their schools, their police and fire service, and their healthcare, and that had a place in the community where they celebrated their culture and taught young people their culture. What they found was that each of these indicators of advocacy, protest, empowerment, and cultural affirmation was associated with lower risk of youth suicide. And the more of these, a dose-response relationship between the number of markers of advocacy, protest, empowerment, and cultural affirmation with the prevalence of suicide. So actually engaging disadvantaged populations in advocacy, protest, empowerment, and celebrating their culture seem to have positive effects, at least on their mental health. What is holding us back? We need empathy. And I'm going to close on the point of empathy and just end here on what we need. We need not equality, but equity. Equality says, let's give everybody the same thing. You see? But everyone is not starting out at the same place. So giving everyone the same thing does not help to meet the needs of everyone. Equity is saying, let's give everyone what they need in order that they can thrive. And what we need is to move less from equality and looking at where populations are and think of equity. Martin Luther King said, true compassion is more than flinging a coin to a beggar, but it understands that an edifice or building which produces beggars needs restructuring. I'm saying to you today that the inequities by race in the UK, in the US, in other societies are driven by edifices that are producing those inequities, and we need to work together to, in fact, restructure them. Thank you so much for your time and attention today.
Thank you, David. This was just superb. The results are depressing because that's how life is, but your research is just superb. And, you know, as you were speaking, what can be done, and you showed what happened in those communities, I keep thinking, you know, what society are we where people are willing to pay $55 million to spend 8 days in a space? And I keep imagining how many communities we could improve if instead of spending 8 days in a space, people would look to the side and see how much good they can do for their neighbors. But, you know, so let me just confirm one thing. Do you have 10 more minutes or you
yes,
have
time.
Okay. Good. So I want to raise a question. I mean, I have a million questions, but I'll just raise one. And I wanna ask you how much this work you've done have been linked to epigenetics. And there's one faculty in our school that he has developed what he calls the biological clock. And I keep asking him, you know, you gotta do some kind of study where you go to vulnerable communities and you do this biological clock and you see how much people are really losing in terms of years or the age you have right now because of the stresses, the vulnerabilities, the discrimination that people go through life. So are you aware or are you engaged in any studies that link this body of research you showed to us to epigenetics?
I haven't, but I do believe historically when research was done in the 19th century, early 20th century on racial differences, the knee-jerk assumption was that any racial differences was as a result of underlying gene frequency differences. There were different racial groups had different sets of genes. In fact, some beliefs were even that a disease in one group might actually be different in another because of the genetic differences between populations. I think the data is clear, and I don't have time to review it. That no, the gene frequency differences are not an important driver of the racial differences we see. At the same time, there are likely to be large epigenetic differences. And when we talk about epigenetic differences, it's just going back to my point that our body keeps a record of what we've been exposed to. And if I'm saying that race, in fact, in part, reflects populations living under different environmental conditions, biology is not static. Biology is adaptive to the environmental conditions under which we live. And so we should find epigenetic differences. There is a more discussion of this in the literature on race and health. There are good, review papers that make a case for it. We do not right now have a lot of evidence. There are people talking about both epigenetic differences or microbiome differences that we might find in populations. I think it's an emerging area of work. The closest we have come to that, I think, is the studies that are looking at biological aging differences. Some have just looked at, measures of physiological dysregulation at age 55 to 65 and compare different groups. And one study done by Arlene Geronimus shows the average score that whites have at 65, blacks have that score 10 years earlier. And so there's a 10-year difference in biological dysregulation of persons in the same society. And there have been a few studies that have looked at telomere length, which is looking at a measure of aging at a cellular level. So I think there is more interest and work in that area. I haven't personally done any work in that area. I've done work looking at allostatic load differences, but not at epigenetics. But that is certainly a frontier of important work that we need to understand. There's also, I should mention, some interest in even the intergenerational transfer of exposure to some of these adversities, particularly for the indigenous population and some of the experiences that populations have had. And there's reason to think so. There's studies of survivors of the Holocaust in Germany that have documented epigenetic changes that puts individuals who went through that experience at higher risk of PTSD, and they find that they have given that epigenetic effect a change is also found in their offspring. So it's a reasonable hypothesis that there could be intergenerational transfer, but I would think not enough has been done along racial ethnic differences, although people have written about it.
Okay, if you use an expression, the toxic stress, that's the same we use for early childhood development. Absolutely. And I think that brings some hope because there's all this discussion that despite the toxic stress, the brain has a lot of plasticity. So it's not that you can recover 100%, but you can recover some. So I think that brings a lot of hope that, if we do the right thing, I think we can remove a lot of this difference.
Yes.
Lorena, do we have questions from the audience? Oh, Vera, go ahead.
Yes. Thank you, Professor Davis. It's an honor to hear you and all the people who work with us in the peripheries of São Paulo with young people are just hearing you and with the immense pleasure and honor to have you with us today. And I wanted to just do some comments that I heard from them.
Okay.
It is one, is that all of us who are doing this work around the peripheries of São Paulo and Sorocaba and Santos, 3 cities among young people, see exactly what you're describing, right? In everything, every single thing you're describing, we are observing and trying to intervene over it, right? The main issue that we were discussing since the morning is facing COVID-19 is that the lack of community mobilization in the response to COVID-19, right? And many people, many of us came from the AIDS field, HIV/AIDS field, to the COVID-19 field, as myself, right? And there was a tradition of community organization through identities, right? And a way of building identity groups and including Black people, Black women, gay people, right? All kinds of identity groups. And the spread of this disease is totally connected to the, as you called, the segregation of neighborhoods, right? If you know Brazil, you know that poor people and Black people are segregated far away from everything else. They are out of the access to opportunities, and I love this point you made, you brought in your to our conversation, right? And some of the communities we've been working with, like the favela of Heliópolis, have done some of what you're talking about, and including mobilization, right? Yeah. So mobilization is good for your health, right? Yeah. And anti-discrimination education, and it's good for your health, and we have this improved. So my question for you is, do you agree that territorial organization, neighborhood organization, especially in COVID-19, it's very much important, and that's the way we should go to hear people and bring them to the response as a community organization, as you were talking about. So do you think COVID-19, in other words, made the point, right, that segregation and neighborhoods and access to opportunity investments should be the way to go to defeat inequality, inequity, and
yes, I completely agree. I think we need policy change at a higher level to equip at the local community individuals with resources. But yes, I mean, one of the things, even I think in the US, the COVID-19 and the vaccination hesitancy, there are many drivers of it for different population groups. Some of it is political, some of it is more of a trust issue. And one of the things that happens when you have individuals from the local community, one of the issues is having people you trust. And I heard the example when I joined the panel early of the Native American community being so high, and it's because there were people who the community trusted saying this is good. And I think that's one of the things that needs to happen. It is happening in some places in the US where there is an effort to get local pastors more involved, local people from the community that people would trust. Because trust is an issue for populations that have been treated badly by society. I mean, they don't trust what the politicians say, what the political leaders say, what they necessarily hear on television. So I think one of the things that is the empowerment and involvement at the local level can in fact play an important role. But at the same time, we have to find ways that we can give them resources that can really transform the living conditions at the local level.
Thank you.
Lorena, you have a question?
Oh. Yes, my microphone is, so it's an amazing honor for us to have you as part of this meeting. I think so much of what you've said today, you've given us a lot to reflect on and think about. We're really, it's very beautiful to hear your comments, because one of the things why we wanted to do this event is we've thought a lot about concretely, the point of all this suffering is to come out of this experience more with a stronger conviction of the type of society that we want to build moving forward, instead of reinforcing the society that we entered into this pandemic. I'm wondering a little bit in hearing you talk about and hearing you think the comments you made today. I think one of the things that we haven't talked as much about is in what you were talking about, some of these interventions. Perhaps if you could talk a little bit about what was the role of the public policies, and was it really critical? For example, in the community that you talk about the turnaround, you mentioned the major donation, but I think part of it is also that there was a major change in terms of public policies changed also to try to come together with a donation to mobilize and to think about this intersectorality. I'm wondering if you're seeing that in the COVID response, we're seeing those types of collaborations come together. So are you seeing that there's progress in terms of our governments partnering in the US and in the UK, where you're speaking more specifically, but is there a lot of collaborations between community organizations and governments to be rethinking some of these strategies and be rethinking things? You mentioned vaccination, and how this is a really critical area, but I think there's a broader issue that you're talking about. We need to restructure the society we want. And how do we start that conversation around COVID is very hard to do. So I'm wondering if you've seen any seeds of hope of who's doing that, who's having those conversations, and where can we look to as some kind of guidance of where are those light posts that we can look at of people that are leading the charge?
It's a really, really good question. I think it's also a really important question. I think there are few examples. I think, if we look at the COVID in the US context, and I think to a great degree the UK context, it's really heavily driven at a national level by what is being done, and maybe less in the US in addition to the national level, the state level. There are some initiatives I have seen of really involving community groups and using familiar community sites like churches as the places where people will come to, or establishing a fair in the community, with a local organization, and people come to have fun, but they also have available the vaccines there. So I think there are some examples, but I think by and large, the system is still, I worked the National Health Service they were so stunned by the racial data in the UK. By the way, someone had said only the US. The UK also collects racial data. Its census does, but it only started in 1991. Prior to 1991, the British census had never collected data on race. But since 1991, every 10 years, it collects data on race. But in the US, when I work with colleagues in the UK, in the US, we report data on race all the time. In the UK, they seldom report it. And that's why they were so shocked by these findings, because they do not routinely report data on race. So, but they're trying to reform that. They have created what they call a Race and Health Observatory. And I am the only non-British based person on the observatory, where they're trying to, what are the rules for data collection? What are the rules for data reporting? What are the solutions in the area of mental health, in the area of maternal and child health? So they're really trying. They've put 10 million pounds was given to this organization to try to map out the terrain of race and health in the UK and to point to where do we go from here. I would say, as of right now, it's at the national level, it's fairly British. We have are trying to think of solutions and how community can be involved, but I think the government focus is on really at a national level, what is the problem and where are the solutions? And primarily looking at the health policy solutions, what does the National Health Service have to do differently and so on, although it's clear that there are things that needs to be done with the delivery of care and quality of care and access to care. But if we don't change the underlying living and working conditions that give rise to the problems in the first place, it's putting a Band-Aid on. It's not getting at the underlying thing. So I would agree with you that I think the long-term solution lies in the empowering of communities to work collaboratively with others, but they need the resources. So that's why they need partnerships, either with government or civil society. I would say in the US, but I don't know what will come of this. In the US, there are a number of, I don't know what the term used in Brazil, but foundations that have said they are making racism a priority for funding. And not just the Robert Wood Johnson Foundation is saying racism in health is going to be a priority for funding, and the Kellogg Foundation and other Ford Foundation saying racism are priorities. They tend to work more with local community organizations, but exactly what will grow out of it, I think is still to be seen. But I would agree with you that long-term solutions lie with community involvement and community buy-in and community engagement. I think is important to the long-term success.
Yeah, and interesting enough, David, we saw some of this mobilization in Brazil in the communities, the slums, that people organized themselves and they created ways of replacing the lack of the community health agents, and it worked. I mean, that's the thing. We need to give visibility of those initiatives that happen in completely adverse conditions, and they saved many lives.
Right.
And especially at a time when literally, as you showed, it's the same storm, but people are not with the same kind of boats to be able to navigate. And especially, I mean, if you look at a country like Brazil that, it's highly unequal, if you have a government that doesn't have the word inequality in its agenda, and we are leaving a government that doesn't have the word inequality in its agenda, either it comes from the community. Hopefully those people stop going to space and put the money into help the community, or I don't know how it's going to happen. And, I think that's a big challenge we have as a society, how we make things happen literally from the bottom, create the momentum, and then it becomes abolished. But
the other point, and I probably need to leave in a couple of minutes, but the other point, that I think is so important that you just made, and I didn't elaborate on this, but one of the big challenges I think we face is how we build the political will. How do we get the general population to value the degree of inequities and actually to see that these inequities are costly? There have been studies done in the US, and we thought there would be, if you showed people the racial inequities in America is costing the United States government, costing the society something like $300 and something billion a year. That's what it costs. And most of that cost was not additional healthcare expenditure. Most of that cost was lost productivity. If you're looking at people losing their lives prematurely, early, in the most productive areas of your life, it's hurting the economic productivity of the nation, it's hurting the global competitiveness. So making an economic argument. But while, people listen to it, I don't think it's moving the needle. And the real big challenge is, how do we get people to care? Scientists are talking about it as an empathy gap. And that is, you are not moved to political action. You're not moved to say this is unacceptable in our country if you don't feel the pain that others are feeling. And what the research in America shows is that for most Americans, when they look at the plight of the disadvantaged, they blame them for it. So for example, studies show that more than 50% of white Americans say all racial inequities in education and health and everything could be solved if blacks only worked harder. So it's their fault. They're not working hard enough. They don't have the right values, and that's why we have the problem. So if you see the problem, no, you don't have to do anything about it if people are bringing it upon themselves. So to me, one of the challenges we face is how do we tell the story of the plight of the socially disadvantaged groups in our societies in ways that people emotionally connect with it. The research shows that if you feel empathy, if you emotionally connect with the problem, you'll say this is unacceptable, I have to do something. And so I've said that one of the things those of us in the health field need to do more of is to work with communication experts and work with political scientists so that we can better and psychologists of how we can better tell the story, because studies in producing empathy sometimes says you can take the same story by changing 3 or 4 words, you produce an empathic response, whereas the basic facts don't produce it. So how do we get people to care? How do we get people to feel the pain? I think is one of the big challenges, because if people feel the pain, they will say, we have to do something.
Absolutely. And we cannot end on a better note. We started highlighting the need for trust, and
Yes.
we end the day with the need for empathy. And if we can achieve a little of those two things, we would be better. Thank you so much, David.
Thank you
this
so
was
much.
terrific. Thanks for bringing light to those problems. And I hope to see all of you tomorrow for the second day of this event. Have a good night.
Bye-bye.
Good night.